السلام عليكم ورحمة الله وبركاته. السلام عليكم ورحمة الله وبركاته. Welcome to the third and last day of our internal medicine webinar. Today, as we arranged together and I explained in the first day, every session has a subspecialty, and today we will start with subspecialty nephrology and hypertension. And we are proud to have Dr. Khalid Al-Mohsen with us. Dr. Khalid is a consultant nephrologist and head of nephrology department at King Fahd Medical City. Dr. Khalid has been known to be an eminent nephrologist with interest in glomerulonephritis and follow-up of transplant patients. We know him a long time ago, maybe more than 6 years now. And we are so grateful to Dr. Khalid because he's always coming with us every year and supporting Saudi German Hospital Internal Medicine Department. Thanks, Dr. Khalid. And let's start with your presentation about lupus nephritis.
Thank you, and it's my pleasure to be with you. I will start talking about the lupus nephritis. So I will start with disclosure. I have no conflict of interest. This will be the outlines for the first presentation. I'll talk about definition, pathology, impact, and the treatment introduction. Then the second part, I will cover the treatment guidelines. So I'll just give a brief introduction about lupus. So the term lupus was introduced early in the 19th century, and it was introduced to describe skin lesions. Then 100 years later, the disease is systemic and spares no organ. So we have better understanding that it can affect any organ in the body. In 1941, by Klemperer and his colleague, they first described systemic lupus erythematosus as one of the connective tissue disease. So what's the definition of SLE in general? It's an autoimmune disease in which organs and cells undergoes damage initially mediated by tissue binding of autoantibodies and immune complexes. And if we talk about lupus nephritis as organ involved, it's histologically evident in most patients with SLE. If we see how much is the prevalence of lupus nephritis in SLE patients, from different studies, it ranges between 50 to 60% of SLE, and it's one of the most serious manifestation of systemic lupus erythematosus, and usually it arises within 5 years of diagnosis of the general disease. Now, the pathophysiology of lupus nephritis, the autoimmunity plays a major role in the pathogenesis of lupus nephritis, but there are other factors that I'm going to talk about soon. So what is the immune role in that? So there's immunological mechanism leads to production of autoantibodies against the nuclear elements. So if we talk about the etiology, there are multiple susceptibility factors which lead to provoke the immune system, which lead to responses that may be variable in different people. These factors include genetic, immunological factor, and environmental factors. The immunological factors that we might have autoantibodies due to several mechanisms. First one is the antigen specifically directed against the nucleosome or double-strand DNA, which we test for. And this anti-double-strand DNA cross-react with the glomerular basement membrane. The other one is the higher affinity autoantibodies, which may form intravascular immune complexes, which are deposited in the glomeruli. Third factor is the cationic autoantibodies have a higher affinity for anionic glomerular basement membrane. Fourth one is autoantibodies of certain isotypes like IgG and IgG type 1 and IgG type 3, which is readily activate the complement. So we have here autoantibodies and complement play a factor. In patient with SLE, they have poor clearance of mechanism for cellular debris. So these debris work, which result from apoptotic cells. These induce the B cells, leads to production of interferon, and lead at the end to induce of immune system and autoimmunity. And these B lymphocytes, which are normally inactive, become active in SLE and lead to the production for autoantibodies. And one of these antibodies is the anti-double-strand DNA. We will talk about later in the presentation what will be the role of B cells and the treatment for that. In this study, which is published in New England, actually there's a beautiful diagram here which shows the role of the factors that I introduced before, the epigenetic, hormonal, immune regulatory, environmental, and genetic, lead to antibodies production through the B lymphocyte, immune complexes, cytokines release, and T cells. And once we have all these combination of immune response, it will lead to organ damage like in heart, brain, lung, skin, and kidney, in addition to other, which was prescribed well, or described well in this journal. If we talk about genetic factors, actually genetic predisposition play an important role in the development of both SLE and lupus nephritis. And this has been explored over many years by different studies, most of them coming from Europe. And they identified certain antigens, certain alleles, which is identified either to SLE in general or to lupus nephritis. Currently, in my institute, we are running one study identifying these genes, which will be getting the genes from our local area. And interesting, what's interesting that we start to identify new genes, maybe which is not in the literature, which will help inshallah for future treatment. The environmental factors include the ultraviolet light, EB virus, smoking, alcohol, exposure to silica dust. All of these can induce SLE or might induce a flare of patient who is has the susceptibility to develop SLE. I'll talk about the clinical features in terms of symptoms. So the disease can be asymptomatic, so it will be discovered. I'm talking about sometimes lupus nephritis. If we have class like 1 or 2, there will be no symptoms, or even if it is renal limited, we will have no symptoms. The other type can be symptoms of active SLE, including fatigue, fever, rash, arthritis, sinusitis, or CNS. Other type of presentation can be symptoms related to active nephritis, which include peripheral edema secondary to hypertension or hypoalbuminemia. Other variety of presentation can be symptoms directed to hypertension that are commonly associated with diffuse lupus nephritis, which include headache, dizziness, visual disturbance, signs of cardiac decompensation due to long-standing hypertension. What the renal involvement or the manifestation of SLE could, there was several studies have focused on the discrepancy between the clinical presentation and pathological finding at renal biopsy in patients with SLE. As I mentioned before, the disease can be silent. The presentation might arise after 5 years. And the silent lupus nephritis have been reported only in class 2, which usually, and class 5. Both of them, mainly they are non-proliferative. Even if patients with low proteinuria, less than 1 gram per 24 hours, have demonstrated significant renal involvement with proliferative lupus nephritis. So if we classify them non-proliferative, they can be silent and they take time to present. If they are proliferative type, they can present early and will be discovered. The renal manifestation of lupus nephritis, if we look by the frequency of symptoms, proteinuria is almost in 100% of patient. Microscopic hematuria, it's up to 80%. Tubular abnormalities, around 60%. Renal impairments, so it's important to know that it's not necessary that you will have decreased GFR, which range between 40 to 80%, nephrotic syndrome, granular cast, RBGN, hypertension, hyperkalemia, and hyperkalemia can be due to renal tubular acidosis, microscopic hematuria, or acute renal failure, which is the least among them. The differential diagnosis for the SLE could be chronic glomerulonephritis, diffuse proliferative glomerulonephritis, Wigner granulomatosis, membranous glomerulonephritis, polyarthritis nodosa, and RBGN. It's important to know that SLE also patient can present with other manifestation other than the usual classification that we know, which I'm going to present. They can present as FSGS pattern. They can present as minimal change pattern. They can cause secondary MBGN. So it's important to know the different variety of presentation for SLE. Now, how can we diagnose what are the investigation we should do? We should evaluate renal function, like renal function test, especially with someone who have SLE. It has to be on our radar because, as I mentioned, the prevalence is around 60% of SLE. They will have lupus nephritis. Renal biopsy, it's important, and I will talk about it in another slide. The blood test that we usually do, we do full renal profile. We do urine. We check for RBC, for cellular cast, especially RBC cast. We check for proteinuria. The urine checking for proteinuria, we have two ways. Either that we'll do 24-hour urine collection, which is still some nephrologists consider it the gold standard. The other way is that we check for protein creatine ratio, and the normal ratio is less than 0.2, but it can be variable from lab to lab. Another test is the antinuclear antibodies, which is for diagnosis in SLE in general. Antibodies to double-strand DNA, which is specific to lupus nephritis. Complement C3, C4, and mainly those complement correlate more with the proliferative type, but it can be present or low, in type 5. ESR, and again, it is more, if there is increased ESR, it's either with systemic SLE or the class 3 or 4. C-reactive protein, there will be usually no change. Another antibodies, which is not usually available, it is anti-C1q autoantibody, and it's not available maybe in most of the labs. It has less sensitivity than anti-double-strand DNA. But if we have both, and both of them are negative, the anti-C1q and anti-double-strand DNA, the negative predictive value is around 90%. So they are good as combined for negative predictive value. The sensitivity of anti-double-strand DNA, it can reach up to 85 to 90% to diagnose lupus nephritis. Other markers, the urinary biomarkers, can accurately identify active lupus nephritis, mainly in children, like the AGB, seroplasmin, lipoclanin, or LBGDS, and the transferrin. Usually we don't use them. This is mainly for clinical trial or research base. If we do we check the urine for patient with SLE, usually we will look for either that we have dysmorphic RBCs or hematuria in general, or we look for sometimes the cast itself, And cast, it's important if we find hematuria, it's indicated that we have a proliferative type of disease. Regarding the renal biopsy, all patients with clinical evidence of active lupus nephritis, either they are previously untreated, they should go renal biopsy unless there is contraindication. And usually, once we have the result of the renal biopsy, we will go through the International Society of Nephrology classification. Why we have to do it? It's important for disease evaluation for activity and chronicity. It identifies the additional or alternative causes of renal disease. So in patient with lupus nephritis, if we have renal impairment or involvement, it's not always necessary to be due to lupus nephritis itself. It can be another presentation like a side effect of medication. It can be according to a thrombotic microangiopathy and others. It's also important to determine the prognosis and if we are or if we need to start the treatment or not. Now, the indication for biopsy in patient with SLE, if the following is the standard criteria to start it. So either there's increased serum creatinine without compelling alternative cause. For example, someone is dehydrated or someone used non-steroidal. So this is the first criteria. Or we have conferred the proteinuria of 1 gram more than 24 hours. Or we have combination of two factors, which at least confirmed on 2 occasions, either that we'll have a proteinuria of 0.5 gram per 24 hour plus hematuria, or we have a proteinuria of 0.5 gram plus cellular cast. So if we have rise in creatinine by itself, it's indication. If we have a proteinuria more than 1 gram, it's indication. Or if we have proteinuria more than 0.5 with evidence of hematuria or cellular cast. Now, what is the dominant pathology that we will find in the biopsy? So we are looking for mainly IgG, which is the dominant immunoglobulin lupus nephritis. But we still can have IgA, IgM, and we can have the complement as C1q and C3. And in type 4 or in class 3 or class 4, we can have full house, okay? Also, if there is a strong glomerular C1q staining is also suggestive of lupus nephritis, although we have another variety which is called C1q nephropathy. Fibrin, if we find it, is correspond to active lesion, especially in crescent. We have called tubular reticular inclusions or TRI, or are thought to be reflect a high interferon, and we can find them in patient with SLE. Now, this is the classification, and it was produced in 2004. I'm trying to bring the simplified version. So class 1, we have minimal mesangial. I will talk about their usual presentation and treatment in coming slides. Type 2 is mesangial proliferative lupus nephritis. Type 3, it is focal lupus nephritis, and there's less than 50% of glomeruli affected. And if you can see here, we have the classification if it is active and chronic lesions and chronic lesions. Class 4, it is diffuse. That means more than 50% of glomeruli is affected. And also we have classification for A and C and C. The difference between them in types of management, type 3, it is less aggressive, but it is more stubborn, need more treatment, stronger treatment sometimes. Type 4 is more common, most aggressive, but it usually responds to treatment easier than type 3. Class 5, which is membranous nephropathy, and class 6 is that advanced sclerosis, sclerosing lupus nephritis, and usually we have more than 90% global sclerosis glomeruli without residual activity. The histopathology, usually if we do histopathology, we have 3 types of examination under the microscope. We have the light microscope, and we have different staining like like this, or we have the electron microscopy, and I'm showing you just images here. I will not go into details. And also we test for immunofluorescence, and you can see here we are checking mainly for IgG, IgA, C1q, kappa, and lambda. And if we have full house like that, we call it full house if we have all of them are positive. Now we know what's the disease, how to diagnose this, but what is the disease impact? So during the 1950s, when they initially start to diagnose those patients, the 5-year survival rate among patients with lupus nephritis was close to 0 before we have these kind of treatment that we have now. With the new treatment, and what I mean by the new treatment, when they start to introduce the cyclophosphamide mainly, this has led to documented 5 and 10-year survival rates as higher as 85 and 73 respectively. So you can see that the big impact, first, how serious is the disease? So it is a killing disease. The mortality is high. And once we have this treatment, it has a great impact to modify the disease and improve the survival significantly. And the most common cause of death among those patients is cardiac and infection because of sometimes the treatment. The other complication that if we don't treat, it's not only death. So one of the complications that they will have in this stage renal disease, and they will be on dialysis. And how significant and bad is that? If you see here the rate of survival by illness, if you see here this one, long-term dialysis, and this is 5-year survival rate, you can see that almost around 60% of patients on dialysis, they will not complete the 5-year survival. And this is even like comparable to even higher than lung cancer and pancreatic cancer. So this is significant, and how important that we have to diagnose the patient and treat them. Now I will give the just simple introduction about the treatment. Now, the principal goal of therapy in lupus nephritis is that we want to normalize the function if there is renal impairment, or at least to prevent progressive loss of renal function. And why is that? Because sometimes we catch the disease late, there is already damage, and this will be told by the kidney biopsy. The therapy differs depending on the pathological lesion, and it depends on the classification that we will find on the biopsy. So it's important to treat extrarenal manifestation and other variables that might affect the kidney. We have steps. We have adjunctive treatment, primary disease management by immunosuppressive agent, and this is divided into induction and maintenance, and we have the lifestyle changes. The adjunct treatment are outlined here. The first one, which made a big change over years, is the hydroxychloroquine. Usual dose is 6 to 6.5 milligram per kg, or it can be from 5 to 6 milligram per kg per body weight. It is indicated to all SL patients with unless there is contraindication. And how is it? What's the impact of using this hydroxychloroquine? All of us know it is anti-malarial, but it has anti-inflammatory effect. So it lowers the rate of flare, reduce the renal damage, and has less clotting effect. What's important is that we have to monitor the kidney, the eyes annually, because it can cause retinal pigmentation. Although there is a conflicting data that was introduced recently that if we have to check the eyes yearly or not. The other one is the blood pressure control using ACE or ARB, and actually we are trying to reduce the proteinuria rather than controlling the blood pressure. And usually it's indicated if patients have more than 0.5 gram per day, it will reduce the proteinuria by 30% and significantly delay the doubling of serum creatinine, delays the progression to end stage. Antihypertensive, and our goal of blood pressure is less than 130/80. And if we have a choice, it's prefer that we use ACE or ARB. Statin therapy, our target, or we have to use it for patients with LDL more than 100 milligram per deciliter. And as GFR resistance 60 ml, if we have CKD developed, SLE itself can accelerate the atherosclerosis. So mainly we are trying to control the hyperlipidemia if it exists, or try to slow down the atherosclerosis. And also we have to give calcium supplementation to prevent osteoporosis, especially if we are using long-term corticosteroid. And I would refer to the international guideline for osteoporosis prevention in, I think the last one published in 2017. This is what we mentioned about the anti-malaria, and you can see here it's important that the anti-malaria to be used, it to block the TLR, and it's approved in all classes from class 3, 4, and 5. It's important to use it, and just we have to observe for the side effect. The immunosuppressive agent, it depends upon the class of lupus nephritis diagnosed on kidney biopsy along the presence of extrarenal manifestation. Our goals is term long preservation of renal function, prevention of flares, avoidance of treatment-related harms, and improved quality of life and survival. If we talk about class 1 lupus nephritis, which we call minimal mesangial, the treatment as directed by the extrarenal clinical manifestation. So usually this class does not require treatment. Usually it has no effect on kidney function or does not lead to impairment. Unless I don't have systemic manifestation, I will not treat. Class 2, which is class 2 may require treatment, and now in literature they consider it as minimal change disease. So if I have a proteinuria, I will use low dose steroid. I will give it for like 1 to 3 months. I will maximize the ACE or ARB. Class 3, which is focal, and class 4, which is diffuse. This class is serious, and it's considered high risk for progression on this stage. It requires aggressive therapy. And I will talk about, usually it's divided into initial phase, which is induction, and the maintenance phase. I will talk about both of these phases in the coming lecture. Class 5, which is membranous lupus nephritis, generally treated with a steroid, in addition to other immune suppressive therapy. And I'll talk about them later. Class 6, it's advanced sclerosis. Usually at this point, we don't give any treatment to the kidney. We are just treating the extrarenal manifestation. Those patients who are in class 6, usually we offer them either dialysis or kidney transplant. And according to the literature, they have better survival and outcome if they have kidney transplant. This is the key DGUG clinical practice guideline for lupus nephritis and definition of complete response if serum creatinine return to previous baseline plus a decline in the urine PCR to less than 500 milligram per gram. The partial response if there is a stabilization within 25% or improvement of serum creatinine, but not to normal, plus more than 50% decrease in urine protein creatinine ratio. Deterioration is a sustained 25% increase in serum creatinine. This is the American College of Rheumatology for definition of improvement, and they divided improved, not improved, or worsening. I think because of time, I will stop here, and if we have any question.
Thank you, Dr. Khaled, for this nice presentation. And we are checking for the questions. Actually, there is one question regarding lupus patients, how to differentiate between lupus cerebritis and steroid-induced psychosis.
Well, it's not easy. So if we talk about lupus cerebritis by itself, it will need to see if there is a neurological deficit. We might need MRI for brain imaging to confirm it. If it is just psychosis, there will be no focal deficit. And at this point, I would refer it to the expert, to our colleagues in neurology to differentiate.
Okay. If we have a patient with end-stage renal disease secondary to lupus nephritis, when can we do transplant? Keeping in mind some doctors may do dialysis for 1 year to do what is called lupus burn out. Do you like to do transplant immediately or to keep on dialysis for 1 year?
Actually, if we start do the dialysis, the transplant immediately, it's better on the survivor on long term. Of course, if they receive the transplant, they will be immune suppressed, heavily immune suppressed, even more than the lupus treatment itself. Yes, by theory, the uremia in literature, it might kill or make it dormant, the SLE on long term. But if we look at the overall survival, rather than flare of the disease itself, the better outcome, the area that we do the transplant.
Thank you, Dr. Khalid, for this nice presentation. And please stay with us. We will have the other part of the presentation, right? Yes. Or we just finished?
Shall we continue or we will move to another lecture?
No, I think Dr. Muhammad Al-Khwaitar is waiting to start his first presentation. So, معلش, stay with us for 30 minutes with Dr. Muhammad. Sure. Dr. Muhammad, you're here with us?
Yes, I am actually. Yes.
I think you should be grateful to me because I make you meet each other. Okay.
I was just about to say that actually.
يعطيكم العافية. حياك الله دكتور محمد.
أهلا وسهلا دكتور خالد, الله يحييك.
Dr. Muhammad Al-Khwaitar, consultant nephrologist at King Saud University, King Saud University Medical City, and he's presenting to us two nice presentations. We'll start with the first one, then we will go back to Dr. Khalid for his next presentation. We'll start now with estimated glomerular filtration rate, reliability, and limitations. Thank you, Dr. Muhammad. Thanks for being with us. We will enjoy together this presentation, then we'll go back to Dr. Khalid Al-Mawsi.
Thank you so much, Dr. Ahmed, for inviting me. I'm so happy. I'm so glad to be with you today. We're going to talk today about the GFR equations, the reliability and the limitation. First of all, it is really, hard to come after an excellent presenter like Dr. Khalid Al-Mawsi, but I'll try my best to be like him. So, Bismillah ar-Rahman ar-Rahim. This is what I'm going to cover in this presentation. I'm going to talk about the importance of knowing the GFR, some problems that may actually you have while you are reading the serum creatinine, the commonest equations used in the field, and then we're going to talk about the studies that compare these equations, and at the end we'll touch base on the reliability of these equations in estimating GFR. So why should we know the GFR? Does that matter? Is that important? And the answer, yes. We want to know, we want to assess the kidney function. We want to stage the chronic kidney disease. Why is that? Why is that important? Well, in order to provide the best care to the level, i.e., number of clinic visits per year, how often I should do the labs, which kind of medicines that I should prescribe, how about the dosing of these medications, do I need to proceed and do kidney biopsy, or maybe this kidney is already in a bad shape, the kidney function is not that good, the stage is 4 or 5, I don't think I will get anything from the biopsy if I proceed and do it. And in addition, I want also to assess the the kidney for those patients who are willing to donate their kidneys. So that's why it is important to know the GFR. Now, why we have to come up with equations to estimate the GFR? Why the nephrologist, they had to come up with equations to estimate the GFR? Why we don't measure the GFR using, let's say, inulin, or using the nuclear scan, the DTPA, for example? Well, the availability is an issue. And inulin is not available everywhere. The cost is an issue. Inulin is quite expensive. The practicality is an issue. When you screen the patient, especially in our society, where we have a lot of diabetes who are at risk of having chronic kidney disease, if you want to screen them for kidney kidney disease, and you want to know their GFR, and you send them to the radiology department in order to do DTPA scan for all of them, you basically will load the radiology department with a lot of patients, okay, at the expense of doing other important scans for the rest of the patients, right? So it is not practical at all. Inulin, why it's not practical? Because you have to measure the urine actually on an hourly basis, and you have to screen that. You have to give the patients an ongoing IV fluid, and you have to check the inulin level on a regular basis. You have to get the patient in, I believe, for 4 or 6 hours to do all of that. So it's not really practical, okay? So measuring the GFR using the high standards kind of tools is not actually available everywhere. It's not practical everywhere. It's quite expensive. So we have to come up with a solution, okay? We have to come up with equations. All right. So wait a minute. Why we have to come up with equations? Why we don't use the creatinine, the serum level of creatinine? And before I answer this question, let's first know what is the ideal filtration marker is supposed to be like. What are the features of the ideal filtration marker that you and I would like to have in order to assess the kidney function? Ideally, we have to have a marker that is freely filtered. Are you going to estimate the GFR? Then you have to have a substance that is freely filtered. Okay, so you can measure it at the end, right? Okay, so number one, it should be freely filtered. Number two, it should not be secreted from the tubular cells. There is only one way for this material or for this substance to show up in the urine. The only way is by filtration. It should not be secreted. And it should not be reabsorbed, because if it's reabsorbed, then you will not be able to ideally assess the kidney function. It should not be reabsorbed. It should be totally filtered, totally excreted, okay? So freely filtered, not secreted from the tubular cells, not reabsorbed, and excreted and changed. It should not be metabolized inside the kidney. It should be excreted as is. It should be excreted and changed. And in addition, it should not be excreted elsewhere. So the only way to excrete this substance is through the kidney, unchanged in the urine. So let's apply these rules to creatinine. Freely filtered, yes or not? What do you think? If you can answer this question in the chat box or question and answers section, it will be great. Do you think the creatinine is freely filtered? Okay, I see an answer saying no. Any other thoughts? Any other thoughts? Do you think creatinine is freely filtered? or not? Okay. Well, it is not. Sorry, it is. It is freely filtered, actually. So it sounds good in this regard, right? Is it reabsorbed or not reabsorbed? And the answer is, it is not reabsorbed. I think we're doing well, very well with creatinine so far. How about not being metabolized and excreted and changed from the kidney? And the answer is, yes, it is not metabolized and it is excreted and changed. That is wonderful, actually. Huh? But how about creatinine secretion from the tubules? Here I have a problem, actually. So no, the creatinine is secreted from the tubules. It's about 10%, all right? But this 10% would increase when you have an advanced kidney disease, okay? So this is one of the problems with creatinine. How about not excreted elsewhere? Unfortunately, creatinine is excreted elsewhere. It's excreted through the colon, through the bowel, actually, due to increased bacterial creatinase activity. And this kind of activity will be enhanced when you have advanced kidney disease. All right. So because all of that, creatinine is not considered as an ideal filtration marker. Because all of that, we want to come up with an equation to minimize the possible mistakes in assessment of kidney function when you base that only on creatinine. Creatinine is variable, right? And this variability based on the age, all right? When you have a creatinine of 100 in an 80-year-old gentleman is totally different than 100 in 16-year-old. Ethnicity. We know that the Black men and women have actually bigger muscle mass than others. So creatinine is a protein that is excreted from the muscle. When you have bigger muscle mass, you will have higher level of creatinine. So that's why we expect the creatinine to be a bit higher in Black people when you compare it to other non-Black people. How about the gender? We know that the males have bigger muscle mass than the women, than the ladies, right? Than the females. So I would expect the creatinine to be higher in male than in female. And when you lost significant muscle mass, such as in cases where you have to do above knee amputation, here the creatinine will not be so reliable, actually, because you lost significant muscle mass. If you ate a lot of protein the night before doing the blood test, you may actually have higher creatinine than what is supposed to be at. And in addition to that, there were actually different assays to measure the creatinine before they standardized it, I believe, in 2001 or 2003. Okay, so because all of that, we have to have a kind of math equations in order to overcome these problems, in order to have better estimate of glomerular filtration rate. Okay, I'm gonna go over the very famous equations in the field. The old one is the Cockcroft-Gault equation back in 70s, right? And if you notice here, the body weight is one of the items in the equation. It depends on the weight and not adjusted for body surface area, and that's why it tends to overestimate the GFR. Okay, because we know the weight does not always reflect the muscle mass. It could reflect the fat, and the fat does not produce creatinine. Okay, so this equation would overestimate the GFR, and they found it to overestimate the GFR back in 1970s, where we have low incidence of obesity. How about now when we have, higher incidence and prevalence of obesity? I think it will overestimate the GFR at the present time. It estimates the creatinine clearance, okay? And the creatinine clearance is measured by the 24 urine collection. And we know that part of the creatinine is secreted from the renal tubular cells and doesn't always reflect the GFR in the urine. So again, it will overestimate the GFR because you will have a lot of creatinine in the urine, and you would assume that this is that this creatinine that you're seeing in the urine is only from the creatinine that got filtered through the glomeruli, and that estimation is partially true. It's not totally true, because I know that 10% or maybe more than that will actually be secreted without filtration from the renal tubules. In addition, it was not adjusted for standardized creatinine assays. How about any other equations in the field? Yes, we have the MDRD equation, and the MDRD equations, it was driven from a study. The MDRD group, renal disease study group, was published in 1999. After standardization of the creatinine assays in 2005, they actually re-express it. Okay, they kept in their consideration the age, the gender as well. Okay, the gender was not taken into consideration when they did the Cockcroft equation. Okay, while here we have the gender, we have the age, and the serum creatinine as well, in addition to the body surface area. 1,600 patients, 1,628 patients. The mean age was 51. I'll look at that. It was driven from a CKD population. Okay, the population of this study, all of them, they have CKD with mean GFR of 40 ml per minute. They are non-diabetic. Most of them are white. So you could argue with me, and you could have some concerns about that. If the MDRD equations was driven from a study population whom are white and non-diabetic with significant chronic kidney disease or with GFR of 40, I have some concerns. How is it valid when you have near normal creatinine? Is it valid for general population, not the only white? How about diabetic CKD patients? Would you consider this equation in those kind of patients? Can I use it for kidney donors, for screening for kidney donors? And how about the Black people? How about the Hispanics? They are not represented in this study. And these concerns actually about its accuracy in normal or near normal kidney function tend to be true. In several studies, this equation was found to underestimate the GFR in healthy persons, and when the measured GFR is more than 60. So it seems that it is not the perfect equation that we are looking for. Yes, it is not, and it was not. So what should we do? Well, before that, if it's underestimate the GFR, do you know what does that mean? You will include more patients of CKD, and you will diagnose them with CKD. Okay, in the United States, the prevalence of CKD after MDRD has increased by 3%, and 3% is quite significant. It's about 26 million. Okay, and what is the impact of that? Well, you may do actually frequent blood testing. You may insufficiently dose the drugs based on that. You may withhold important CT scan tests with contrast because you believe that this patient has chronic kidney disease stage 3, and you don't want to harm the patient. While it is not true, because MDRD tend to underestimate the GFR. And you may also consider unnecessary aggressive cardiovascular risk reduction. You may consider cardiac cath when you have like atypical chest pain, because you believe that this patient has significant kidney disease, and you know that the significant kidney disease is a risk factor for cardiovascular disease. So you will do thallium scan, and if the thallium scan is equivocal, you may proceed and do so you will test the patients, you will work up the patients aggressively because the MDRD underestimated the GFR. So we have to have another equation. EPI, CKD EPI. It was published in 2009. And again, they took into their consideration the gender and the serum creatinine as well, in addition to the age and the ethnicity as well. So they estimated the GFR in adults from serum creatinine database. The database was actually pulled from 10 studies, around 8,000 patients, and they validated this equation against 16 studies. They included the CKD and patients without CKD. They included diabetic and non-diabetic. The mean GFR was not 40 like in the MDRD. The mean GFR here was actually 68. So what did they found? They found that the CKD EPI, after validation against 16 studies, is as accurate as MDRD when the GFR is less than 60. Okay, so when the GFR is less than 60, it's accurate as MDRD. But when the GFR is more than 60, it's actually more accurate than MDRD. So that. So when they came up with this equation, they looked backward to the patients who are classified to have chronic kidney disease based on MDRD, and they reclassified those patients based on CKD EPI. Okay, and they found that, well, we have now lower prevalence of CKD. It's down from 13.1 to 11.5%. I have to say that elderly was not represented enough in CKD EPI. I have to say that Hispanic and Asian race was not represented enough too. Okay, so when we reclassify, does that matter? So, okay, it's down from stage 4 to stage 3. Does that matter? Well, to answer this, we have to have an impact on the hard outcomes. They actually looked at the risk prediction using CKD-EPI equation, MDRD study, and they found they looked at the all-cause mortality in this meta-analysis, cardiovascular mortality and end-stage renal disease. And the result was, when they compared the MDRD, 24.4% general population cohort were reclassified to a higher GFR category by EPI, okay? The prevalence of CKD stage 3 to 5 was reduced from 8.7% to 6.3%, okay? 34% participants with MDRD of 3B, 45 to 59, were reclassified to 3A, 60 to 89. And these participants had lower incidence rates of outcomes, all-cause mortality, cardiovascular mortality, and end-stage compared to those who are not reclassified. So this reclassification actually tend to be useful in terms of predicting the outcomes. And that did give a strength to CKD-EPI equation. And that's why in the KDIGO guidelines in 2012, they recommended that the clinical laboratories should report eGFR creatinine in adult using the 2009 CKD-EPI creatinine equation. Okay, so that's good. It seems that CKD is probably more accurate than MDRD when the GFR is more than 60. But you know what? Let's see how good is this equation. How good are these two equations against the measured GFR, against the inulin, against the nuclear scan with DTPA? Okay, so in CKD-EPI study, they found that 85% to 88%, 85% of the MDRD and 88% of AP of eGFR values were within plus minus 30% of measured GFR. So when you do a measured GFR for all of these those patients, you will find that 88% of CKD-EPI patients, or the 88% of patients with whom we did CKD-EPI, the result actually is within plus minus 30% of the measured GFR. Is that good or bad? 88% sounds good. But look at this. Look at the margin of error here. It is 30% plus minus. That's a lot. That's a lot. Okay. What do I mean? I mean if the measured GFR is 60, the estimated GFR could range from 42 to 78, 30% above, 30% below. And 42, you know, it's 3B, and 78 is actually class 2. So it's quite significant when it comes to the true GFR. Okay, as we said, 12 to 15% outside the range. 12 to 15% outside the range. The range of what? The range of 30 plus minus. Okay. Let's see another study. Well, this is a study in people with diabetes and preserved renal function. And they found, again, that 80 to 90% of both equation of GFR, the measured GFR, the estimated GFR fell within plus minus 30% of the measured GFR. In another study, in type 2 diabetes, they found that the both equations actually underestimate the GFR by 20 and 24 ml per minute respectively. This is a comprehensive study that was done, that was published in 2008 in Nature. And I want you to look at that. So P30 is the marginal, the 30% marginal mistakes when you measure the GFR. In this study, for example, they found that the MDRD and clinical EPI, in 30 to 45% of patients, the GFR error was more than plus minus 30. So it is even not that accurate in some of the other studies. In another study, the MDRD, they found that the P30, 20 to 25% of patients, was actually, it was more than 30% possibility of having mistakes when they compare the measured to the estimated GFR. In another study, there was a poor agreement with measured GFR and estimated GFR. It was about 30 to 60% of patients with estimated GFR, they found an error in the classification of CKD stages. And look at here. They did not look at the P30. They looked at the margin of error of about 10%, P10. It's not 30. Look at the results here. In 70% of the patient, estimated GFR error was more than plus minus 30% of the measured GFR. So what I want to tell you that the persistence of the error in the equation is due to the poor markers that we're using. We still have a problem with the marker that we're using here. It's not the problem with the equation. It's not a problem with our ways to come up with equations with our mind, where we want to come up with a mathematic kind of calculation to bring or to assess the kidney function, to bring the kidney function to the front. And the main problem is the marker that we're using is not the ideal marker. And that's why at the end, we don't have a good estimation for our equation that would estimate the kidney function very well. The acceptable limits of agreement should not exceed, based on the authors of this review, should not exceed plus minus 10% between the estimated GFR and the measured GFR. Those sounds difficult, but it sounds reasonable, to be honest. 90% of estimation should fall within this margin. Okay, I would take it if 90% will be within plus minus 10, but it will be very hard to take an 80 or 90% will fall between plus minus 30. That's I believe too much. And they recommend actually direct measurement of GFR in a situation where careful monitoring is required, like in transplant. So what is the key point? What are the key points here? Creatinine is not a good marker of filtration. The margin of error, P30, used to validate the equation against measured GFR is really wide. With such margin of errors, clinical trials assessing the progression of kidney disease should be interpreted carefully. Up-to-date CKD-EPI seems to be one of the best available equations to estimate the GFR when creatinine is near normal, when the GFR is more than 60. Careful assessment should be considered upon estimating GFR in elderly, in body mass index of less than 20, in cirrhosis, in amputated patients, because those kind of patients are not very well represented in the previous studies. Thank you so much.
Thank you, Dr. Muhammad. But again, what we will do in our clinics, we will do CKD-EPI equation. This is the end, although we have some comments on it.
Yeah, I think the best equation up to date is the CKD-EPI. If the creatinine is near normal, if the measured GFR is more than 60. If the patient has an advanced kidney disease with the GFR of less than 60, then with the measured GFR of less than 60, then we believe that both are good in estimating the GFR, or let's say comparable.
So simply we will use CKD-EPI, and if GFR is below 60, we can use MRD, Madrid equation. But what about the measured GFR? Do you like to do measured GFR through inulin or creatinine clearance or urea clearance, or?
Yeah, well, I mean, the inulin is quite difficult to do, and it is usually done in the hospitals where they have research centers. Okay, what we do usually is the DTPA, the nuclear scan, and we don't do it routinely, to be honest. As I said before, because of the availability, the cost, and the practicality as well. I know the CKD-EPI is not, and CKD-MDRD are not the best when it comes to estimating the true GFR, but it's the best up to date. It's the best until now. When I'm in doubt, let's say, I'm not really sure whether this patient has chronic kidney disease or not. His creatinine is 100, but he is tall. You know, it is a possibility that this guy has actually a normal kidney function. Okay. Yeah. When I do the CKD MDRD, or sorry, CKD-EPI or MDRD, I found that his GFR, let's say, is 65%. Okay, and I'm doubting that this is true. Okay, I did the urine analysis. The urine analysis is bland. I did ultrasound. Ultrasound is totally normal. So here, before I label the patient as a chronic kidney disease patient, I may consider actually doing the DTPA, for example, or inulin if it is available.
In Egypt, we were doing DTPA or renal scanning for some patient where we need to know the exact GFR. But in other patients, we used to do creatinine clearance and urea clearance and see and divide it by 2. Take the sum of both and divide it by 2. Do you have a comment on this practice?
It has been tried actually, especially in advanced liver disease patients. You do the urea clearance and the creatinine clearance, use both of them, and you take the average. It's been used, but it's not widely used, to be honest. It's not.
And also cystatin C is also in use, but not widely used. Also the same.
Cystatin C, it's not very widely used as creatinine. Okay. we may consider using cystatin C when you have low muscle mass. Okay.
Exactly. Yes. To
We
overcome
may
some
consider,
issues.
yes, we may consider doing cystatin C when you have, let's say, equivocal, let's say, and as I said before in the example, when the patients come to you with creatinine of 100 and you're not really sure whether this is a chronic kidney disease or this is normal, here you may consider as well doing cystatin C. But you have to make sure that the lab is familiar with the test and they can do it.
Yes, exactly.
Yeah,
Yes.
and because
Okay.
I think the machine, because of its infrequent use, some of the lab technicians, they don't have actually good experience to deal with it, and the machines may not be validated against an outside machine.
Okay. Thank you. We will be waiting for the next presentation by you, but first we will go back to Dr. Khalid Al-Mawsim to continue with him what is new about lupus nephritis. Dr. Khalid, Dr. Muhammad, you stop sharing, right? Okay.
Yes.
Dr. Khalid, you can start sharing your screen. Yes.
Yes.
Thank you.
بسم الله الرحمن الرحيم. Thank you, Dr. Ahmed. I will start the second part. As we mentioned, in this part, we'll talk mainly about the treatment in general, and we'll talk about different scenarios or situation where we have to individualize the treatment. So in induction phase, and this is mainly we talk about the class 3 and 4, we have the initial therapy with corticosteroid combined with either cyclophosphamide or MMF. If patient have worsening lupus nephritis, like rising in serum creatinine, worsening proteinuria during the first 3 months of treatment, a change be made on alternative regimen, and I will show the diagram for that. Now, this is just a diagram for patient who is already diagnosed based on the criteria that we discussed in the first lecture. So we will do kidney biopsy, and we will decide if the patient has non-proliferative lupus nephritis, which is classified into class 2 or class 5, or the patient has proliferative lupus nephritis, which can be class 3 and 5, 3 or 4, class 4 as active or chronic, or class 3. The non-proliferative can be class 5 with nephrotic range proteinuria. And just to observe that this class 5 is nephrotic range proteinuria and this one is subnephrotic. And the treatment, it's different. The non-lupus nephritis kidney disease is around 5%. It can be related to lupus podocytopathy, thrombotic microangiopathy, as we mentioned. It could be interstitial nephritis, cryoglobulinemia, or acute tubular necrosis. And the treatment depends on the underlying condition. If we have proliferative type lupus nephritis, or if we have non-proliferative type, like class 5 with nephrotic range proteinuria, we will use immunosuppression and we will take the protective measure. If we have non-proliferative, we'll go to immunosuppression only to treat the extrarenal manifestation, and we will use kidney protective measures. So how we will induce or give the induction? So we will give methylprednisone. If you can see here that we will give pulse now for 3 days, and the dose, it range from 0.25 to 1 gram per day over 3 days, and we can follow it with oral prednisone, or if it is not like RBGN, we can give oral prednisone from the start, and we will taper it. The new guideline, the new KDIGO guideline, which is released, will be released soon. It was preliminary released for review, and the European guidelines, actually they prefer that you minimize the amount of steroid that's given as induction. So they prefer that if you can just go with 0.5 gram per day, then rather than going for 1 gram. So this is for the steroid. If we talk about the other immunosuppressive, So what is approved is the MMF or Silcept, 2 to 3 grams per day in individualized doses for 6 months. We can give the IV cyclophosphamide, which is 500 milligrams every 2 weeks for 3 months, or the oral cyclophosphamide, and can be up to 3 months, or the IV cyclophosphamide NIH, for which is giving monthly for 6 months. If you notice here in the induction, it's only steroid plus either MMF or cyclophosphamide, so we don't have any other immunosuppressive agent. Plus that we will give the hydroxychloroquine and other protective measure. And this phase can be extending from 3 to 6 months. What we'll do is that we will observe and we will see what's the outcome of the induction. If there is worsening of the disease at any point, we will choose alternative induction therapy. So if we give MMF, we'll give cyclo or the other way around. If there is no improvement with both way, this when we will consider refractory disease, and we will discuss it in a following slide. Also at this point, we might consider repeating the kidney biopsy to confirm the diagnosis, to detect the activity versus chronicity, and to evaluate some complication factor like TMA or others. If during the induction there's a stable kidney function or improvement, or there's partial or complete remission, then we will start the maintenance therapy. And the preferred agents are the MMF. Now, in the new recommendation from KDIGO, they took azathioprine from the recommendation and they put it in special occasions, like if patient cannot tolerate the MMF, or the patient is pregnant. The idea behind that is that although that they are almost equivalent, but MMF is superior in terms of induction in several trials. So the maintenance phase will continue 12 to 18 months, and we'll see if there's partial remission, the treatment will be indefinite. If there is complete remission within 18 months, we will consider tapering off the therapy, and I'll talk about what will be the expected therapy for patient who has responded. For treatment of class 5, if the patient have subnephrotic range of proteinuria, which is less than 3.5 grams per day, and there is a preserved kidney function, the treatment is hydroxychloroquine, kidney protective measures as ACE, statin, and we will use immune suppression for non-renal SLE manifestation. We will consider giving immunosuppression to treat class 5 if the proteinuria increase more than 1 gram per day, and we will continue to monitor. For patients who have nephrotic range of proteinuria in class 5, or there is a worsening kidney function, we'll give the Plaquenil plus the usual measures, and we will consider giving the immunosuppression in terms of MMF, or we can consider giving calcineurin inhibitor plus corticosteroid. We might give cyclophosphamide plus steroid, or we can use multi-target therapy, which means we give a steroid, MMF plus CNI. Last regimen will be Imuran plus corticosteroid. Now, I talked about the doses of steroid, but so I will skip this. But we have to remember about the steroid and why the consensus come, or the recommendation is to reduce it by the KDIGO. Actually, the side effect of immunosuppression, it carries another burden more than the disease itself. Especially in our community, the prevalence of diabetes is around 30%. If we add steroid large doses on long term, the incidence of diabetes will increase, especially if we use medication like tacrolimus. And the tacrolimus-induced diabetes is a well-known entity. So we try to minimize the side effect. And this is the common side effect that we face with steroid in general: the osteoporosis, ocular toxicity, infections, maybe malignancy with other immunosuppression, infertility and early menopause, plus others. If we compare about the induction of both regimen, cyclophosphamide and MFF, which one is better than or in trials or different regimens, which one is better? Actually, they are equal in the outcome. Maybe we have less infection and side effect with MMF. We have different protocols like the NIH, Eurolupus, and oral cyclophosphamide. We usually we prefer for Eurolupus protocol for cyclophosphamide in patients who are young and they are looking to be pregnant, because it has less effect on the fertility. Or we give the MMF as alternative to preserve the fertility. So this is the difference between the different protocols for cyclophosphamide if we compare it to MMF. Important consideration when we give cyclophosphamide, we can use the sodium 2 mercaptopurine, which is MISNA. It also minimizes the risk of hemorrhagic cystitis when cyclophosphamide is given as IV bolus. Usually, this is coming from the hematology or the hematological malignancy evidence, where they use large or mega doses of cyclophosphamide. Maybe we don't face this as much in nephrology. So there is a conflict between nephrology, shall we give MISNA or not? So it depends. There's no harm to give it. We just need to remember that the lifetime maximum dose of cyclophosphamide is 36 grams, so we have to keep it in mind. This is especially when you give oral cyclophosphamide, we will have larger accumulative dose, and this will lead to increase the chance of hematological malignancy later in life. The dose of cyclophosphamide should be decreased by 20% or 30%, depends on the GFR. To minimize the bladder toxicity with oral cyclophosphamide, we suggest to instruct the patient to take cyclophosphamide in the morning and drink extra fluid. And they try not to hold the urine for a long time, so they have to have frequent voiding. We try to protect the fertility. Women should offer prophylaxis with leprolide, and men, we give them injection of testosterone. And usually leprolide, we give it 2 weeks before the dose. There's a cryopreservation for sperm banking, our other option, which is available in some centers. Now, how can we predict the outcome of is our treatment is working or not? So after 2 months, if there is more than 25% of reduction in proteinuria or normalization in C3, C4, they're likely to show good clinical, there is a likely to show a good clinical and renal responses. After 6 months, decrease in serum creatinine and proteinuria to less than 1 gram per day predict good long-term outcome. This has come from a certain study. Now, what is the definition to response to treatment? Maybe this, we mentioned it before, but it's important to repeat it again. So complete remission or complete response is return to serum creatinine to previous baseline, plus decline in the urine protein creatinine ratio to less than 500 milligram per gram. Partial response is stabilization or improvement, stabilization by 25%, or improvement serum creatinine, but not to normal, plus 50% decrease in urine protein creatinine, protein to creatinine. And if there is a nephrotic range of proteinuria, improvement require more than 50% reduction in the urine protein. Deterioration, there is no clear definition of deterioration in lupus nephritis, but there is suggested definition. The sustained 25% increase in serum creatinine is widely used, but it's not validated. Now, what are alternative regimen to use if patient fail the treatment of the initial treatment with cyclo, or there is a failure of treatment? We have rituximab. I'll talk about the trial which talked about rituximab. We have Imuran. It's second line protocol. It is less effective than cyclophosphamide or MMF. Usually, it's preferred for patient who's not tolerant for maintenance therapy or patient who's planning to be pregnant. MBA or Myfortic. It's alternative to MMF, and it has less GI side effect. We have strong evidence coming from the transplant, but we don't have anything in the literature of nephrology. Cyclosporin or tacrolimus, they can be used in the multi-target therapy, and they can be used for patients who have class 5. We talked about rituximab, so we have different trials starting from 2009 and 2013 and other trials. If we see here for the randomized control trial, if we compare the standard treatment to rituximab in both EXPLORE and LUNAR, there was no difference in complete or partial remission. If we see the two observational trials, there is some improvement after one year. Unfortunately, this is an observational trial. So as a conclusion now, we don't recommend to use rituximab as induction therapy or maintenance therapy, but we can use it for someone who has refractory disease in addition to the standard therapy, and it is working, or if patient has another indication for rituximab other than lupus nephritis. Now, what is the duration of therapy? There is no evidence to help determine the duration of the maintenance therapy. Actually, there's no trial, but from different trials, they took the average from 7 RCTs, the average time is around 3.5. And sometimes it's up to 5 years. So usually we give the treatment, it should not be less than 2 years. Even if patient in remission, we try to minimize the most serious drugs like steroid, because we want to minimize the side effect, but we will continue the maintenance therapy at least 2 years, and usually the average is 3.5. The other lifestyle changes for lupus nephritis, that they should drink enough fluids to stay well hydrated. They have to take a low salt diet, especially to prevent high blood pressure, avoid smoking and drinking alcohol, exercise on a regular basis. They have to limit the cholesterol and treat it, and avoid medication that can affect the kidney like non-steroidal. In addition, they can apply, as we mentioned before, that the sunlight can cause a flare, so it's better that they use sunscreen, and usually is recommended the SPF is around more than 60% is good to reduce the infection. Other thing that should be counseled about the pregnancy, and I will talk about it in coming slide. What is the relapse of lupus nephritis? So treated with initial therapy followed by maintenance that was effective in induction in the original remission. And if there is a sign of a flare again, this we consider it as a relapse. So if we have an induction or maintenance and the patient is in remission and develop relapse, and the classification of relapse is in this here in this table. So we have mild, moderate, and severe. So if there is increase in glomerulohematuria to more than 15 RBC, or there is a recurrence of more than 1 RBC cast, this is mild. If it's considered moderate if baseline is less than 177 millimole and increase of 17 millimole or micromole. And you can see here the criteria. We have both creatinine criteria and urine protein criteria to classify it between mild, moderate, and severe. So once we have the classification of relapse, we have to start the treatment. Usually the treatment of relapse is that we use the same original therapy that we use for induction, which was successful, and we maintain. If the relapse is not responding, then we will consider it as refractory. The other situation that we might face in lupus nephritis is if we have SLE or lupus nephritis with TMA. At this point, we have to consider two factors. Either we are dealing with antiphospholipid syndrome, and it happens when the immune system mistakenly attacks some of normal proteins in the blood. And it can involve the kidney in systemic lupus either way. So how to diagnose it? We can diagnose by using some blood tests to look for lupus anticoagulant, anticardiolipin, and beta-2 glycoprotein, and we have to confirm it to 2 occasions. The other differential for TMA, we should suspect HUS or TMA, and in this case, we have to send for Adams T13. The treatment for TMA actually is that we have to, it depends on the how aggressive is the antiphospholipid. So we have to consider anticoagulation if there is an evidence of thrombosis. We can give aspirin or long life anticoagulation as indicated by the condition. Now, lupus nephritis and pregnancy. Usually, if patient is in a flare, they should be counseled about not to get pregnant until the disease and under complete remission. And the ideal time to achieve remission is, or to be in remission before they get pregnant. There was before controversy, either it's 1 year or 6 months. And according to the new guideline, 6 months of complete remission is enough to get pregnant. The other point is that we have to be careful to stop the teratogenic medication or that we know will cause harm to the baby. For example, the MMF, enough time. Methotrexate, for example, need to be stopped enough. ARB at least 6 weeks before the conception time. And we can switch the patient to alternative like Imuran or another medication to control the disease. The contraindicated doses is, or contraindicated is high dose steroid. It can lead to hypertension and diabetes, especially the risk goes up. But we need to use it if a flare happen. MMF, cyclophosphamide, methotrexate should be avoided because they are teratogenic. And class 3 or 4 with a crescent consideration of delivery after 28 week of viable fetus. This is if we have rapid deterioration kidney function. Otherwise, the new recommendation is that we will keep or try to delay the delivery up to 32 weeks. It's recommended that we administer low dose aspirin of pregnancy, and the benefit of administering aspirin, it happens if you give the aspirin before the 16 weeks of gestation. If you give it beyond the 16 week, the benefit is not there. Now we come to the other scenario, which is the refractory lupus nephritis, which is not responding to the usual first lines of treatment. And what's the prevalence? It's up from different studies, 20 to 70% in the international literature, 25% among SOT patient with lupus nephritis. So it is a significant entity or group of patients with lupus nephritis. The impact, the patient survival at 10 years, if patient achieve complete remission is 95%. If they have partial remission is 76%. If they are refractory, it reduces the survival to 46%. And the linear survival at 10 years, if they have complete remission is 94%, partial remission is almost half, is 45%. And the refractory cases is 19%. So it has a major impact on the renal survival. We have to, when we face a patient with refractory, always we have to consider the non-adherence. And why is that important? Because we are dealing with a group of young patients. This disease usually affects young people. So only 50% of individuals with chronic disease comply with the recommendation. This is in general, not related to disease or treatment or age. The non-adherence should be strongly explored before escalating, and this from a different study. Now, what will be the treatment approach? We switch cyclophosphamide to MMF. This is as induction, and we will see if there is response or not. After 6 months, as I mentioned, we switch. If there is no respond again with the new regimen, then we have to consider the biopsy. And what is the role of rebiopsy in refractory cases? If there is a rapid increase in serum creatine, we have to exclude crescentic disease. New or worsening proteinuria in those treated with the proliferative lupus nephritis, we have to rule out concurrent class 5. If there is resistant or partial response lupus nephritis, we have to assess the disease activity, exclude other possible pathology as acute interstitial nephritis or drug toxicities. And the implication of doing repeating biopsy in a study done for 77 patients, only 1/3 of patients with partial remission and 14% of patients with no remission had no histological evidence of active disease. Concurrent, they found class 5 in 11%, and moderate to severe interstitial inflammation is only 41%. Now, if you switch to alternative after 3 or 6 months, there is no improvement or worsening, and you consider this is as refractory. So either that you will give rituximab, as we said, as 1 gram repeated in 2 weeks. You might consider a multi-target therapy, or you have to consider other options like intravenous immunoglobulin or cyclophosphamide can be given, leflunomide or plasmapheresis or immunoadsorption. It depends on the situation that you have. Most of the people go to rituximab now, as it has been there is some evidence from observational trials. This is a new biological therapy for lupus nephritis. Rituximab, it's not new anymore. We have the ocrelizumab, we have abatacept, and they showed a good or similar response compared to the standard therapy, but usually they are added to the standard therapy. They are expensive. The side effect of infection is high, so we need larger trials and RCTs to consider it. I will skip this because of time. This is the ongoing trials, and I will talk about the voclosporin and belimumab in just 2 slides. Now, what's voclosporin? Voclosporin is a CN9, and it was tried in 2 doses, high and low dose compared to placebo. The low dose, which is interestingly of voclosporin added to MMF or steroid for induction of active lupus nephritis, resulted in superior renal remission than the standard. The problem with that they have more side effect. So it was not promising from that trial. The other trial, they compared the low dose by itself. On the longer term, they compared the voclosporin small dose compared to MMF and steroid, and they looked after 52 weeks for primary endpoint. The reduction or the renal response at 80 weeks, we can see here that in voclosporin it was 40%, while here it is 22%. Again, we have good result of using voclosporin, but the safety profile might be a concern. The latest trial, which we'll talk about, is the BLISS, where they used belimumab as in addition to the standard treatment compared to placebo. If we can see the percentage of the complete remission compared to the placebo group, there is the odds ratio here is 1.7, which is significant. Again, the safety of the drug in terms of infection might be a concern. The second thing is that the cost of the drug is high. So maybe, yes, it's promising. We have better outcome compared to the standard treatment, but at this point, we might consider it as patients who are refractory or they have recurrent disease, rather than start a standard induction of therapy. I think now here is just now the belimumab compared the outcome of complete remission here between the belimumab and the placebo. It just compared what we mentioned in the previous slide. Because of time limit, I will stop here, and I would like to thank you.
Thank you, Dr. Khalid. It was a very nice presentation. And actually, we don't have any questions. And for the sake of the time, we will move to Dr. Muhammad. Really, Dr. Khalid, we are so grateful to you. And we wish you to join and give trust to us next year, inshallah.
Inshallah. Thank you so much, Dr. Ahmed, and to our colleagues.
Dr. Muhammad, are you with us?
Yes, I am actually.
Okay. Dr. Muhammad Al-Khwaiter will start the next presentation with what is the target blood pressure, the dilemma story. Thank you, Dr. Muhammad, for this nice choice.
Thank you so much. Just give me 1 second. Okay. Am I, do you see, guys, the PowerPoint now?
Till now, yes,
No?
yes.
Yes?
Now it's okay. Now it's okay. Just now.
Now?
Oh, it's okay. It's
okay. Okay, sure.
Yeah, it's perfect.
Bismillah ar-Rahman ar-Rahim. Thank you for having me again. We're going to talk now about the blood pressure target, the dilemma story. It's actually a very huge topic, but I tried my best to focus and make it more clinical and practical. So what I'm going to talk today about, I'm going to talk about the definition of hypertension. I'm going to talk about the ways of measuring the blood pressure and the landmark and the cardiovascular risks and the landmark trials in the field. And then we'll have a comparison between the guidelines. So what do we mean by blood pressure? What is the definition of blood pressure? It is defined as the level of blood pressure at which the benefits of treatment unequivocally outweigh any risk of treatment, as documented by the clinical trials. And this is based on the European Society of Hypertension and European Cardiology Society guidelines that was published in 2018. What do I mean by this? I mean, you're going to give the patients a blood pressure pill, but this blood pressure pill should not cause side effect. Okay, if you are able to control the blood pressure without side effects, then that's actually what you want to have. Okay, so hypertension is defined as the level of blood pressure at which the benefit of treatment unequivocally outweigh the risk of the treatment. How do we measure the blood pressure? Well, we have the routine office blood pressure. The office blood pressure, we do it using either the manual or the automated oscillometric device. And the oscillatory method with the manual cuff is the technique used in most of the clinical trials of antihypertensive therapy. Okay. How about the non-routine or the standard methods? The non-routine or the standard methods, we have more than one actual example. The automated oscillometric blood pressure monitoring. And this is a device that you use in the clinic. You usually check the blood pressure of the patient in sitting position several times, like 4, 5, 6 times. And the machine will average the readings to you. Okay. Other methods, home blood pressure. So basically the patients have the blood pressure device at home, and you ask him the automated one. You ask him the automated one is the usual one used at home. So you will ask the patient and instruct him to take like 4 readings on a daily basis for like 7 days. And when he comes to you, you see the blood pressure readings and you average them. The ambulatory blood pressure monitoring, here the patients will wear a blood pressure device, and this blood pressure device will automatically check the blood pressure every 15 to 30 minutes during the daytime and every 30 to 60 minutes during sleep for 24 to 48 hours. Okay. Again, most of the studies actually use the usual way, the oscillatory method with the manual cuff. Okay. But what do we mean by high-risk patients when we say high-risk patients? Because this group, there was a focus on them in the study that tested the blood pressure targets. So what do we mean by high-risk patients? Well, we mean any patients with established cardiovascular disease, yani patients with coronary artery disease, patients with cerebrovascular accidents, and patients with peripheral vascular disease. Any diabetic patients is considered as a high risk. Chronic kidney disease patients is a high risk. Heart failure patients is a high risk. Old adults, more than 65, is considered as high risk, and multiple, and if you have multiple cardiovascular risk factors. What do we mean by multiple cardiovascular risk factor? Well, we know this, SCORE, the American Cardiology Association, and American Heart Association, and American Cardiology Society as well. We have like what we call the cardiovascular risk assessments in adults. So based on the race, the sex, the age, the cholesterol, the systemic blood pressure, and whether you are on hypertensive medications or you're not on hypertensive medications, whether you are diabetic or not, whether you are a smoker or not, and the score here will be calculated as a 10-year risk. When it is 15 and above, this is a significant risk. Okay, so let's go to the studies that have looked at the blood pressure target. In 1970s and 1980s, the blood pressure target was about 140. Sorry, it's not 149. It's 140 over 90, based on several studies that were published at that time. However, in 1998, HOT trial was published, and this was the first clinical trial to determine whether further intensive lowering of blood pressure reduce cardiovascular outcomes or not. They included 18,000 patients, and the age was 50 to 80. The baseline diastolic blood pressure was 100 to 115, and they randomized them into 3 categories: less than or equal to 90, less than or equal to 85, and less than or equal to 80. And overall, there was no significant difference in cardiovascular events between these 3 groups. Okay. However, when they sub-analyzed the patients with diabetes mellitus, they found significant, actually, reduction in major cardiovascular events when the diastolic blood pressure is less than 80. Okay. Compared with those patients whom their blood pressure is between 80 and 90. Not only this study, but there was another study in 1994. I should have mentioned that actually before the HOT trial, because it was published before it. So the MDRD study, it was done in the renal population. And what did they find? They compared actually the usual blood pressure control, 140 over 90, with more aggressive blood pressure control, 125 over 75. And they found that there is a slower progression of chronic kidney disease in intensive group when the proteinuria is more than a gram. So HOT trial found that lowering the diastolic pressure to less than 80 is beneficial for patients with diabetes. And the MDRD found that if you have chronic kidney disease, if you are able to lower the blood pressure to less than, with a target of 125 over 70 in patients with proteinuria of more than a gram, that would help in slowing the progression of chronic kidney disease. So based on these 2 trials, the GNC7 guidelines in 2003 made the target as less than 130 over 80 for diabetics and chronic kidney disease, but less than 140 over 90 for others. In 2002, the ASK trial was published. It was done on patients with high blood pressure and chronic kidney disease. Around 1,000 African Americans, long-standing hypertension with slowly progressive chronic kidney disease, not diabetic, they don't have glomerulonephritis, only long-standing hypertension with otherwise chronic kidney disease. They have mild proteinuria, only 100 milligrams per day, approximately. and they assigned the patients to two arms: the 140/90, the usual, and the intensive, the 125/75. And they were able to achieve the targets at the end. Okay, they followed them up for 4 years, and the result showed no change in the GFR between the groups. So that there was not actually well, I mean, I can't say it contradict the MDRD study, because MDRD was only, the intensive blood pressure was only beneficial when the patient has proteinuria of more than a gram. Here, the median is approximately 100 milligram per day, so they have low grade proteinuria, and it did not show any significant difference in the GFR between the two groups: the group with the usual, the standard blood pressure control, and the other group with intensive blood pressure control. And in 2005, another study, they call it REN2, the blood pressure control for renal protection in patients with non-diabetic chronic renal disease. So you're saying that the patients, if the patient is diabetic, controlling the blood pressure with intensive target probably would be helpful. How about the non-diabetic patients? It is an RCT trial, included good number of patients for kidney diseases, of course, but maybe not good number of patients for high blood pressure patients. They were not diabetic, as we said, but they have proteinuric nephropathy. So we have an evidence that the CKD with proteinuria, they may benefit from from intensive blood pressure control. And we have another evidence that those patients with diabetes, they may benefit from, or they will benefit from intensive blood pressure control. How about CKD, but proteinuric and non-diabetic? So they assigned them to conventional, as we said, diastolic less than 90, or intensified. And the intensified group, the target was less than 130/80. Okay, and well, I mean, the result did not show any benefit from further blood pressure reduction. So that is a bit against the MDRD study that showed that, you know, the patients will benefit from blood pressure, from lowering the blood pressure if they are proteinuric. Here is another study in non-diabetic patients, in proteinuric patients, but contradicting the previous study. So so we have now so far 2 negative studies: the ASK trial, okay, African chronic kidney disease, non-diabetic, negative. Another RCT trials, non-diabetic, proteinuric with significant proteinuria and chronic kidney disease, and negative. In 2007, the ACCORD study, the very famous study, was published. In the ACCORD trial, they enrolled around 4,000 patients with type 2 diabetes mellitus this time, and either known cardiovascular disease or at least 2 additional cardiovascular risk factors. And they assigned the patients to 2 groups: intensified group with a blood pressure target of less than 120, or the usual with less than 40. And here, it's a very important, actually, piece of information. They used the automated blood pressure measurement, okay? The one that as I explained it before, the patient will come to your office in the clinic, he will sit, we will put the automated machine will check the blood pressure 5-6 times, and then will average the blood pressure reading for you, okay? Which is not routinely used, not everywhere. So they use this actually method of measurement. Now, is there any difference between this method and the usual, the routine blood pressure method? Yes. This method, actually, it was found that it will, the blood pressure readings will be less by 5 to 15 millimeter mercury in comparison with the systolic, or in comparison with the usual, the routine, the oscillatory method of measuring blood pressure. Anyway, the follow-up was around 4.7 years, And what was the result? There was no significant difference in the annual rate of primary composite outcome. What was the composite outcome? The non-fatal myocardial infarction, the non-fatal stroke, or death from cardiovascular causes between the intensive versus the standard therapy group. And there was no difference in the annual all-cause mortality rate between the intensive and the standard therapy groups, or in the rate of death from the cardiovascular disease between the groups. The only significant thing was the significant reduction in the annual rate of total stroke, of non-fatal stroke, okay, but not the fatal stroke. The reduction was in the total stroke and the non-fatal stroke. In addition, they reported adverse events related to the antihypertensive drugs that happened significantly with the intensive group. And it was associated actually with even higher rate of acute kidney injury. So it was not positive as they expected before. So the ASK trial, the ACCORD trial, and the REAN2 trial, all of them came out negative for intensive group. The only exception, non-fatal stroke. So based on these trials, the European Society of Hypertension and the European Society of Cardiology in 2013 and GNC8 in 2014 have changed the blood pressure target. It's not anymore less than 130/80. They have changed it back to less than 140/90, regardless of the associated conditions. The only exception for diabetes, the European guidelines, not the GNC, the European guidelines, they said less than 85, not less than 90. So it was 140/90. Then after the MDRD study and the HOT study, they changed it down to 130/80. Then back again after ACCORD study to 140/90. And we were following this until SPRINT trial, the very famous SPRINT trial that was published in 2015 in the New England Journal of Medicine. And in SPRINT trial, they included around 10,000 patients. And most of them, more than 90%, they were on antihypertensive therapy. So they are not new hypertensive patients. The systolic blood pressure, at the beginning was 130/180, and they had to have, in addition to the high blood pressure, they have to have one or more of the following additional risk factors for cardiovascular disease. The age, if it's more than 75, it's enough. Or they should have, they have to have established cardiovascular disease, known to have coronary artery disease, stroke, peripheral vascular disease, subclinical cardiovascular disease. What do we mean by subclinical? We mean when you do the coronary artery imaging, you will see some calcification by CT scan, or if you have left ventricular hypertrophy, or if they have an glomerular filtration rate between 20 and 60. They consider that as a cardiovascular risk factor, or 10-year Framingham risk score to calculate the cardiovascular risk if it is more than or equal to 15%. So they included those kind of patients. They excluded diabetes. They excluded symptomatic heart failure, any patient with history of stroke, any patients with proteinuria of more than a gram per day, or 600 milligram if they do the albumin to creatinine ratio. And they excluded the frail patient in nursing home residents. So the mean age was 68-year-old. The mean index of the body mass was 30. The mean Framingham score was 20%. The mean blood pressure was 140/78. And the clinical or subclinical cardiovascular disease was present in 22% of the patients. Why I'm telling you these characteristics? Because it's important to consider it when you decide to treat or not to treat, when you decide whether this is the target or not the target. Okay. And patients were randomly assigned to standard treatment, less than 40 or less than 20. The diastolic blood pressure goal was less than 90 anyway. So the blood pressure during the trial was, they measured the ambulatory blood pressure measurement, in the office. The trial was stopped and terminated actually early after a median follow-up of 3 years. And the key findings from the SPRINT trial were as following. Intensive therapy significantly reduced the rate of the primary endpoint, primary endpoint. It's a composite of myocardial infarction, acute kidney syndrome, stroke, heart failure, cardiovascular death. Okay. Intensive treatment also significantly reduced mortality. Acute kidney injury occurred more frequently among patients assigned to intensive therapy, however. Okay, and more side effects like syncope happened with the intensive group as well. So the positive findings is quite impressive. The composite or the primary points, the composite of myocardial infarction, ACS, stroke, heart failure, or cardiovascular death was significantly lower with the intensive group. The mortality was lower in the intensive group. Very striking, actually. There is a side effect, acute kidney injury, but 95% of the patients, they regained their kidney function and they did not need to alter the dose of the medications. So it suggested that older patients, hypertensive, non-diabetic, at high risk for cardiovascular disease, you would try to target an ambulatory blood pressure measurement of less than 20, as this would reduce the mortality and prevent all, cardiovascular events and mortality as well. But many patients enrolled in SPRINT trial had controlled hypertension at the baseline. So that's not the ideal kind of population that we may, see when we want to enroll patients in an RCT to test whether the target is helpful or not. The rate of adverse event reported may be an underestimate of the adverse events rate. Why? Because they said, well, you can't 100% eliminate the bias, okay, in RCTs. You may not keep in your mind that the patients who are frail, probably you did not include them. Patients in nursing residents, you did not include them. And in general, the patients that are enrolled in the trials they might be healthier than the usual patients coming to your clinic. So yes, they have mild adverse events in this study, but the point is probably this may underestimate the real adverse events when it comes to reality. NICE 2019 guidelines, they actually criticized the SPRINT trial in many aspects. So they said the committee considered that the use of these devices, they meant the ambulatory blood pressure measurement device, would lead to lower blood pressure readings than in routine UK clinical practice. And they are true. If you want to do the oscillatory, usual office visit blood pressure measurement, okay, you can't target the 120 here because the target of 120 was by the use of the ambulatory blood pressure measurement. And as we said before, you have to increase the blood pressure measurement by 5, 10 to 15 to reflect the usual routine blood pressure measurement in the office. So they said, well, in this study, they used a device that is not commonly and widely used in the UK, and that was one of the things that that made us unable to generalize this target to our population. In addition, they had some concerns about some patients because in the trial, when they achieved the blood pressure target, they stopped the medications and they followed them. And they said this is not the usual in clinical practice, and this may actually had an impact on the results. Okay, maybe those patients who have very mild hypertension, and you were able to even take off one of the medications, probably they will be healthier than the group of patients, right? And they may give us a good result, while in reality, they should not have been included in the study from the beginning. And the committee as well also discussed some concern about the applicability of the population. For example, participants had higher cardiovascular risk level, including many with pre-existing cardiovascular disease or renal impairment, and were already receiving treatment before the study started. I'm not going to, well, I mean, so that are the concerns from the NICE guidelines. And we said some other concerns in the previous slide as well. So NICE guidelines, they do not take the 130/80 as the target. Actually, they are still keeping the 140/90 as the target in general for the patients in order to, I mean, the target that you will target when you consider treating patients with high blood pressure. I'm not going to talk here about the definition, the difference in definitions between the European Society and the American Heart Association. I'll go directly to the comparison. So we said that the American Heart Association, based on SPRINT trial, they changed the guidelines, their guidelines, and they changed the target of the blood pressure from 140/90 that was taken from ACCORD trial to less than 130/80. However, NICE guidelines did not agree with that because of the points that we have mentioned. Let's see the other guidelines. So let's see the European guidelines. So in European guidelines, well, this is 2013. No, I should have put the 2018. The European guidelines in 2018, actually, the blood pressure target was down to 130/80, down to 130/80. The exception is the old patients. The old patients, they allow the blood pressure to be between 130 to 140, okay? But look at the American Heart Association, it's all 130/80, 130/80, 130/80 for all kind of patients, including elderly. And we have to be very careful actually in elderly, especially if they have significant carotid stenosis, for example, if they have non-lacunar infarct in the past, okay? So you have to balance between lowering the blood pressure and maintaining good perfusion. Okay. How about, let's say, NICE? We said NICE guidelines, it's 140/90. They did not change it, okay? European, they changed it to 130/80, and the exception goes for elderly. How about the Canadian? Well, the Canadian, actually, they are a bit different. They still believe that 130/80 is the target for CKD, whether they are proteinuric or non-proteinuric, and for patients with, for patients CKD with diabetes, CKD with diabetes, whether they are proteinuric or non-proteinuric. But they still considering the 140/90 for CKD with no diabetes if they have no proteinuria, and they still consider the 140/90 for renal transplant, and they still consider the 140/90 for elderly. Why? Because of lack of evidence. Renal transplant were not included in the study of SPRINT trial. They said if the patient, any patients who are not included in the study of SPRINT trial, we may not target the 130/80. We may consider the 140/90. KDIGO guidelines based on 2012, but this is actually before the SPRINT trial. So we have to review the latest one. This is not the latest one. So in general, after the SPRINT trial, there was a major shift in the practice toward the blood pressure control and the blood pressure target. The AHA guidelines is targeting 130/80 for all patients, almost. The European, they have some preservation for patients who are elderly. The Canadian, they still consider 140/90 for the group of patients who are not included in the sprint trial. So patients who have low risk of low cardiovascular risk, they will not target 130/80. They will just keep it 140/90. I think that's all for my talk, and I'm happy to receive any questions. Sorry, is there any question?
1 minute, Dr. Mohammed. I'm still reviewing.
Sure. Okay.
There's only one question here. When we measure blood pressure, we measure it in peripherally. But to be more accurate, we need to measure the blood pressure centrally. So is there a machine to measure, like ultrasound, to measure the central blood pressure?
We don't do this. It's not practical. You know, we have the arterial
lines.
The arterial lines, but this is usually in ICU settings.
Yes, yeah. And we don't need to measure it centrally because all the trials are standardized on measuring it by a special method, like we said, like you stated before.
So if you manage to put as an arterial line, so which blood pressure target that you will look for?
Yes, exactly. Yes.
You have evidence? No, we don't have evidence.
Yes, complete physical and mental rest, semi-sitting or sitting position like this, non-dominant arm. These are the criteria we measure the blood pressure with. Okay, but I want to have your experience, sir, about white coat hypertension and this issue. What do you do in your practice to know that this patient has white coat hypertension or not? You go for ambulatory blood pressure monitoring or home monitoring?
Yeah, well, I mean, this is a very valid question. That means a lot for actually not the nephrologist, but all the general practitioners, to be honest. Because as we know, many patients, come to our clinic and they are a bit anxious. That's why the blood pressure tend to be on the higher side. We expect the blood pressure to be higher than what it's supposed to be at home. So when I see a high blood pressure in my visit, I don't take it as is. And I ask the patient to do it at home, like the home blood pressure. I ask the patient to go home to do it 3, 4, 5 times a day for 4 or 5 days, up to 1 week, and to touch base with me again. If I see that the blood pressure is high, then I will take it as high. If I'm in doubt, well, I mean, the patient has no the appropriate, let's say, cough. The patient is a bit obese. The patient is not that adherent. I don't really think that the patient is doing it as what I told him. Then I will do the 24 blood pressure
ambulatory
monitoring, especially if the patient on many medications and they are old. So I'm not, I don't want to give them an intensive kind of treatment with that, as this might result in dropping the blood pressure. They may fall, and if they fell at home, they may get fractured. So, which means a lot to them. Yeah. So this is what I basically do.
I have another question. Sometimes when we want to start ARBs or ACE inhibitors to proteinuric patients, we find that their blood pressure is not tolerating. Like you start like irbesartan 150 milligram once daily for a patient, and he come in the next visit with blood pressure like 100/70, 100/60, and complaining of hypotensive attacks and dizziness. What do you do in this situation?
Well, if the blood pressure is borderline at the start, but I think they may benefit from ACE or ARBs, I may choose lisinopril, for example. Lisinopril, I can start from 2.5 and increase the dose up accordingly. I'm not a big fan of lisinopril because in order to titrate this medication, it may take a long time for you. But I may consider lisinopril in the group that you have said, Dr. Ahmed. borderline blood pressure, I'm afraid of having low blood pressure, I may use it. I may use losartan as well, 50 milligram, because losartan, if you compare it to the other ARBs, I mean, the irbesartan or valsartan or telmisartan, it's the weakest one between them. So I may start with small dose like 50 milligram.
Because some patients are so strict to the doctor orders. When you tell them salt-free diet or low-salt diet, they become so strict with themselves. So
absolutely, and that's why
I'm noticing this hard patient, and at the end, I don't know what to do with this proteinuria, to give or not to give.
Well, there are some group of patients where we cannot give ACE or ARBs, especially when the blood pressure on the lower side. Any patients with a blood pressure of less than 110, I would think twice actually before giving them ACE or ARBs, to be honest.
Okay, thank you, Dr. Muhammad, and inshallah we will see you in the next symposium. Thanks for trusting us and giving us your name to be put beside SGH. Thank you, and wish to see you soon.
Thank you so much. I'm so honored to give this lecture, and I'm so happy to be with you guys. And thank you very much for giving me this opportunity and for having me tonight.
Okay.
See you, inshallah, next year.
And now we will have the next presentation for Dr. Ala El-Ali. Dr. Ala is infectious disease consultant, and he already joined us. We have a presentation under the name of Approach to Sepsis. Thank you, Dr. Ala, for joining us. Unmute.
Yeah. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much, Mr. President, and thanks for all the panelists, for the participants, the attendees. And I wish, inshallah, today we will present a very fruitful presentation, inshallah. I hope we will learn from each other, inshallah ta'ala. Okay, so I can share my slides, isn't it?
Yes, please. Start by share screen. Yes. It appears on my side. Thank you, Dr. Ala. You can start right now.
Okay. Okay. Hi again. This is Dr. Al-Ali. I'm a consultant in internal medicine and infectious disease, and today we will talk about how to approach patient with sepsis. Our agenda today will start with a smooth introduction, pathogenesis, microbiology causes of sepsis, and then we will touch the clinical manifestation of sepsis, approach to the patient with sepsis, and finally with management. So we'll start with the introduction. This is Rory. Rory is a 12-year-old boy in Queens, New York, cut his arm playing basketball in school. The next day, his parents worried about his fever and leg pain, took him to his pediatrician, and then the day after, the emergency department at Langan Medical Center, he was discharged with a diagnosis of upset stomach and dehydration, but died 3 days after from sepsis. So infection unnoticed, taken seriously, and then turned to unstoppable, and Rory gone. So the question is, how many Rory we miss in our practice? Actually, sepsis is a very important situation, and it's very top emergent situation in the hospital. Because of that very long time, maybe more than 30 years, a lot of campaigns, a lot of studies, a lot of RCTs, everything done for that. They ended with the sepsis classification, as we know, the SARS definition, the sepsis, severe sepsis and septic shock. And a few years back in 2012, they ended up with a bundle of 6-hour severe sepsis and septic shock. And lately, in 2016, the third international consensus definition for the sepsis and septic shock ended with this definition that the sepsis is life-threatening organ dysfunction caused by dysregulation of response to infection, appropriate physiologic reaction in association with confirmed or strongly suspected infection or any other stimulus that activates inflammation is a systemic inflammatory response. That's SARS, what we are called SARS. So what's SARS? SARS is two or more of the following manifestation: either heart rate more than 90, respiration rate more than 20, the hyperventilation status that's equal to the CO2 pressure less than 32, temperature more than 38 or less than 36, white blood cells more than 12,000 or less than 4,000. But sepsis, however, is no longer simply defined as infection or suspected infection plus two or more of SARS criteria alone. So this is, in brief, sepsis is a mix of bacteremia, infection in anywhere, maybe fungemia, maybe viremia, maybe other, plus the systemic response like secondary to trauma, burns, or maybe even pancreatitis. So if you concentrate here, there is so many causes can give you a sepsis picture, but it's not infectious in nature. So please, if you want to apply score for sepsis, now use the SOFA score. This is SOFA score. SOFA score is consists of alteration of the PO2 over FiO2 ratio, the worsening thrombocytopenia, escalation of total bilirubin level, hypotension with or without use of vasopressors, escalation serum creatinine, or declining in urinary output, declining Glasgow scale score. This is the SOFA score. And if you have a patient outside the ICU, you can use the quick SOFA. What's the quick SOFA? It's two of these three: altered mentation, respiration rate more than 22, and systolic blood pressure less than 100. And on the opposite of Dr. Al-Khwaiter lecture just before, they want to decrease the blood pressure. We are always looking to increase it. So if we talk about septic shock as a subset of sepsis, it's a profound circulatory, cellular, and metabolic abnormality associated with a greater risk of mortality. The most recent established criteria for this subset is the need for vasopressor to maintain MAP more than 65 and elevated serum lactate more than 2 despite adequate fluid resuscitation. What's the pathogenesis of sepsis? First, we have activating of the recognition receptors, and then we have a problem with the oxygenation and nitrogen species. And then we will have a problem with coagulation and impaired anticoagulation status, endothelial dysfunction, then mitochondrial dysfunction, and then ended with apoptosis, that's programmed cell death, immune suppressed states that reduce clearance of the pathogenic. What's the microbiology of sepsis? If we take any septic patient or a patient with sepsis or suspected of sepsis, we need to look carefully for the epidemiology. So if we see here the North America different than the South America, that's North America maybe fungal infection, gram-positive infection is more there, and maybe some spirochetes. In South America, maybe there is a tropical infections we need to think about. The old world, that's Europe, everything possible there. In Africa, also tropical as well. Yani we need to make sure that no tropical disease in that patient causing sepsis. Russia and Asia, a lot of gram-negative, a lot of mycobacteria, viruses as well. Southeast Asia, maybe we have MDR bacteria, especially gram-negative. In Saudi Arabia, we are endemic to almost everything because of Hajj, because of Umrah season. A lot of patients we deal with here, so we need to be open-minded in our country. Microbiology of sepsis can be everything: gram-positive, gram-negative, anaerobe, fungal, viruses, etc. This is how infectious disease think about gram-positive. It's very tough and full diagrams, and this is as well for the gram-negative. So don't worry about this. Just call me anytime you need. Gram-positive bacteria, usually we have to think about gram-positive bacteria in normal patient and immunocompromised host, asymptomatic patient particularly susceptible to encapsulated gram-positive bacteria such as Strep pneumo. And these pathogens are usually community-acquired infection, less likely to be hospital-acquired, but it's there. And always think about associate with skin and soft tissue infection, pneumonia, or meningitis. Usually, if we are talking about gram-positive bacteria, we are talking about staph, strep, and listeria. While gram-negative bacteria, it's more with immunocompromised people like chronic corticosteroid use, chemotherapy, and solid organ or hematopoietic transplant patient, neutropenic patient, chronic medical conditions like hemodialysis, diabetes, cirrhosis, or catheter patient, usually nosocomial. In contrast, that gram-positive, usually community here, it's usually nosocomial origin and may be associated with multi-drug resistance. Asymptomatic patient also particularly susceptible to encapsulated gram-negative like Neisseria and Haemophilus influenza. If we are talking about gram-negative, we should think about Enterobacteriaceae like E. coli, like Klebsiella. Also, Pseudomonas is a very big and common cause. Acinetobacter, Salmonella causing enteric fever, cholera, Yersinia, and don't forget to think about Neisseria and Haemophilus influenzae. What about anaerobe? Anaerobe usually easy forgotten, although it's uncommon, but it's common with traumatic injuries, invasive disease to cause necrotizing skin and soft tissue infection and antibiotics abuse. Always think about it with antibiotics abuse. While what's the causes of what type of anaerobic bacteria we have? We have mainly three types: that Clostridium and Fusobacterium and the Bacteroides. The Clostridium importance is that Clostridium difficile strongly associated with antimicrobial use, as you notice in our in every ICU actually and every healthcare facility. What about the other? Other is less common, but it's not less common anymore, because fungal infection now is recognized well. A lot of outbreaks of fungal infections, a lot of infections can caused by fungal with immunocompromised patient, chronic corticosteroid use, chemotherapy, transplanted, neutropenic, any chronic conditions, any prolonged antibiotics use. You should think about Candida species, mold infections like Aspergillus, like zygomycetes, like mucormycosis, and for less extent like Cryptococcus neoformans. While viruses, think about all herpes viridias, CMV, herpes simplex, and varicella zoster, Epstein-Barr, all can cause sepsis. What's the causes of sepsis? Sepsis can cause either non-infectious or infectious pattern. But the message here, always please, always think about the non-infectious causes, because it's very important. This is the non-infectious causes. Just imagine how many patients we have with BE, DVT, MIs, acute coronary syndromes, acute leukemias, tumor lysis syndromes, hemorrhage, intracranial, subarachnoid, malignant hyperthermia, severe pancreatitis, etc. All are non-infectious and can cause sepsis, even septic shock, and can mimic the infectious causes. So please make sure your patient is non-infectious before think about the infectious causes. Also, you need to think about a trauma patient, surgery, post-burn, thyroid storm, actual acute adrenal insufficiency, malignant neuroleptic syndrome, like in patient after haloperidol use, solid organ transplant rejection. Always think about these causes. While the infectious causes, many, you need to think about bacteremias, very important, vascular access infections, lower respiratory tract like pneumonias, intra-abdominal infections, urinary tract infections, endovascular infection like infective endocarditis, skin and soft tissue infections, central nervous system like meningitis. This is the infectious cause. All of us, most of us knows these and aware about, but please think about the non-infectious cause as well. Don't forget it. What's the clinical manifestation of sepsis? If you concentrate about this slide, you will find some non-specific, however common sign like fever, chills, rigors, irritability, confusion, lethargy, tachypnea, hypoxia, acute respiratory distress, respiratory failure, hepatic and renal failure. All these can be with sepsis, but think about this is non-specific for sepsis, can be noticed with so many other causes. So it's non-specific, however, it's common. If we approach patient with a sepsis, we should start always with history. Take a very good history, like starting with age. Age always give you a hint about some infectious or some illnesses can be associated with age, like UTI, pneumonia, intra-abdominal infections, MIs, etc. Then go with the very detailed history presenting illness. It's important to establish in a chronologic fashion that the onset of symptoms and events, and then go carefully and deeply with the past medical history, recent infection, chronic medical illnesses, malignancies, chemotherapy, surgeries or its complication, implant prosthesis, and indwelling catheter. And finally, before you finish, just make sure that medication and allergies, have a list of prescription, and especially over the counter, herbal, antimicrobial, any type of allergy. Make sure that patient is not taking some medications can mimic the symptoms, like beta blocker can give you a bradycardia, corticosteroid and non-steroidal can mask the sign and symptoms of infection. Social history, so many clues here, and always this is the treasure actually in the history. You need to go carefully with this if you can, for sure. Country of origin, immigration, and the prior country of state or state of residence, a travel history, whether he's exposed to somebody or to anything. Did he vaccinate before he traveled? Did he take any prophylaxis during? What about the general vaccination status? What's the occupation? Is he smoke, alcohol, using any drugs? What's the hobbies, leisure activities, pet and animal exposure, and sexual activity? This is very, very important. Physical examination, physical examination, while most vital signs are non-specific, fever might be the first indicated of sepsis. Pulse should be increased 15 to 20 beats per minute for each 1 degree increase in core body temperature greater than 39. Diastolic blood pressure usually decreased as a result of sepsis-induced decrease in systemic vascular resistance. Hypoxia and tachycardia or tachypnea may also be present, but in general, it's non-specific. Skin examination, very important, can give you a hint and clues. Check the surgical site, check the traumatic wound, check the pressure ulcer and vascular access site, any edema, warm, tenderness, purulent erythema, any erythema greater than 4 millimeters, it's significant, surrounding the vascular access site that indicate vascular site infection. Petechia and bleeding from vascular access may indicate DIC. Also think about Staph aureus, Neisseria gonorrhea, or Neisseria meningitidis in case of disseminated infection like Berberic macular papular or Pully. Pseudomonas aeruginosa can give you ecthyma gangrenosium. Candidiasis can give you diffuse erythematous, painful nodules. Furuncle or IV drug injection site should be also sought and may indicate deep skin and soft tissue infection. Genuine lesion, osseous nodes, and splinter hemorrhage may suggest infective endocarditis. While the head exam, you can do fundoscopy looking for rota spot, systemic candidiasis. You can looking for jaundice. However, it's non-specific, but may indicate biliary tract infection, conjunctival petechial lesion like an endocarditis, gingival inflammation, and poor dentation can give you a head and neck infection, or for this extent can give you a necrotizing pneumonia situation. Also, you can look for impaired oxygenation, tachypnea, sign of pulmonary consolidation, suggested pneumonia, complicated paranomic effusion, and emphysema. Chest exam is very important. While the cardiovascular exam, looking for any new diastolic, especially diastolic murmur or any change in the existing murmur if you are aware about the previous one. All of these may suggest endocarditis or maybe infectious in cardiovascular system. Abdomen, pelvic, and rectal exam, very important. So many cases, it's hidden infection in this area. So you need to do abdominal exam thoroughly and looking for any previous surgeries, any surgical scars, cholecystectomy, hysterectomy. You need to do each part of it separately, like if you are doing abdominal exam, looking for tenderness, guarding, looking for any peritonitis picture or any collection may indicate abscesses. Internal and external rectal exam is very important, can give you a hint about perirectal abscess. It's a very hidden area, and so many times we can simply forget to do that. It's very important. And also prostatitis, you need to look for that. Bimanual pelvic exam for the female patient looking for pelvic inflammatory disease, give you a big hint, and inshallah yani, you will not miss that patient if you did it thoroughly. Neurological exam looking for, you know, meningitis, meningoencephalitis, also musculoskeletal, looking for any osteomyelitis, any septic arthritis, or any prostatic infection if he did any surgery before. Laboratory studies, however, most of us asking laboratory just for medico-legal concept, but it's give you a very big, and important hints. If you ask for CBC, looking for leukocytosis and leukopenia as well. Thrombocytosis can be very helpful if you are think about fungal infection. You might have thrombocytosis. Also basic metabolic panel like creatinine. The high creatinine may reflect how bad is the disease with the patient, and also it's important to make a very good antimicrobial dosing when you start antibiotics. And what about liver enzyme? Think about the alkaline phosphatase and total bilirubin if you are looking for biliary tract. Also, isolated alkaline phosphatase, as you know, can indicate liver abscess. Abnormal coagulation can be indication for a sepsis as well, decreasing in fibrinogen level. Serum lactate is very important, and it's easy to do. More than 2 lactate, serum lactate more than 2 can indicate tissue hypoperfusion and the need for fluid resuscitation. Procalcitonin and ESR, CRP are very important, but sometimes it's not that specific, especially procalcitonin. Procalcitonin, if it is less than 0.5, so sepsis is not less likely to be secondary to infectious causes. If it is more than 2, more likely to be secondary to infectious causes. If it is between 2.5 and 2, can be non-infectious conditions like trauma, post-surgical, heat stroke, mesenteric infarction, and pancreatitis. A lot of very big mistakes and common actually that they are sending only urine culture. Urine culture alone is not enough. Actually, urine microscopy is more important than urine culture. You need to do both of them together and make sure that it's a clean catch and not from very old Foley's catheter. Looking for cystitis, pyelonephritis, and renal abscess. Blood culture, it's the cornerstone of the lab. You need to do blood culture about from 2 different sites, about 2 sets you need to send for from the blood culture. Each set not less than 10 ml in each. And please do, if you do blood culture, do it from 2 different sites, one from peripheral and one from the central, or any catheter lasted more than 48 hours. Sputum and gram stain culture, it's important. However, you need to make sure it's the WBC of the sample is more than 25 and epithelial cell is then less than 10. Otherwise, it's inadequate sample and you need to repeat it. Wound or abscess culture, don't do superficial swab. It will be wrong, definitely. Please do tissue sample. It will help a lot and will give you a very confident result. Stool studies, looking for any infectious causes of diarrhea, especially C. diff, colitis. Radiograph, you know, we have X-ray, we have ultrasound, we have echo, and we have CT scan. X-ray looking for pneumonia, looking for bowel perforation in the abdominal cavity. Ultrasound, if you are, it's an non-invasive, good imaging study, but for the superficial area only, not for the deep structure. Can evaluate biliary tract and can evaluate the pelvic etiology for sepsis. You know, even ultrasound Doppler can help you with the vascular issue. What about echo? Echo, if you are thinking about endocarditis, you have two types of echo, transthoracic and transesophageal. Both are okay, and you need to do if you are thinking about endocarditis. CT scan, you know, chest and abdomen is a very important source of infection and can cause severe sepsis, and we have to do it with contrast if you are thinking about abdominal issue, looking for intra-abdominal abscess or some complicated pneumonias. Management of sepsis, we have three main components. First, we have to establish early goal direct therapy and initial resuscitation, then antimicrobial therapy, and then lastly with the source identification and control. The treatment for sepsis consists of immediate effort to stabilize the patient, followed by identifying the underlying cause and formulating the treatment plan that particular condition. Early goal-directed therapy, initial fluid resuscitation. You need to give good amount of fluid, as we mentioned before, 30 ml per kg of a crystalloid within 3 hours. The best solution are the normal saline. You need to do it for persistent hypotension and defined by absolute systolic blood pressure that less than 90 or relatively systolic blood pressure less than 40 from the baseline. Serum lactate more than 2. You need to give a good hydration. What's our goal? To keep the central venous pressure more than between 8 to 12, mean arterial pressure more than 65, and the central venous oxygenation more than 70%. What about vasopressor and inotropic support? Further improve cardiovascular and perfusion. Norepinephrine is the treatment of choice. If you need to give something else, you can follow it by dopamine. Corticosteroid therapy, yes, you need to give for persistent hypotension because of possibility of adrenal insufficiency. The suggested agent are hydrocortisone, and steroid should be weaned after discontinuation of vasopressor and inotropic support. Blood product, you can give RBCs if the hemoglobin less than 7, a platelet if there is insignificant bleed or it's less than 5,000. Glucose control, yes, we need to control glucose, but not tightly. Keep the level between 140 to 180. Use insulin alone. Other supportive measure, yes, you can use renal replacement therapy for certain indications. You can use CVVH or intermittent hemodialysis, mechanical ventilation, and keep the tidal volume 6 ml per kg. Keep the plateau pressure less than 30. DVT and stress ulcer prophylaxis as well, and always prevent the ventilation association pneumonia by elevation head of bed by 30 degrees to 45 degrees. Antimicrobial, this is the cornerstone of the management. We need to give the antimicrobial in the early as first hour to maintain the life and to save the lives, and the rapid of antibiotics administration, the more life you can save. And if you see here, if you the more delay, the more mortality. This is if you give it within 120 minutes, i.e. first 2 hours, it significantly reduces the mortality in the hospital. And also, if you think about antimicrobial therapy, and you should think about it first, and before you give, just make sure that renal function is okay. However, you can initiate a broad spectrum antibiotics covering both gram-negative and gram-positive, but you need to make sure that the source control is controlled as well, as rapidly as clinical practical. A daily assessment for de-escalation narrowing therapy based on culture data and the clinical improvement. There is no standard empirical regimen. Suggested combination of regimen as following. If you want to start any medication for gram-negative, yes, you can start ceftazidime or cefepime. Both are good choices. Also, you can choose doripenem or meropenem. The third option, you can use biptazo, that's the tazocine, piperacillin tazobactam. But make sure if you use ceftazidime and cefepime, there is no anaerobic coverage. So you need to add flagyl or metronidazole as well. If you are thinking about gram-positive, just remember the slide initial I present. You can choose daptomycin, linezolid, vancomycin. Daptomycin, don't use it if you are targeting CNS or pulmonary source. You can use linezolid, but you need to make sure that the platelet is okay. Vancomycin, always make sure that the vancomycin level between 15 and 20, and don't forget the vancomycin level are creepy, so it needs to be monitored regularly. Metronidazole, if you are using ceftazidime or cefepime, otherwise no need for metronidazole unless for certain indication. What about duration? Duration 7 to 10 days is quite enough, and you need to monitor daily for renal function, comorbid conditions, drug intolerance, interactions, susceptibility pattern, and underlying infectious process. Source control. Source control is the key. Within the first 6 hours of sepsis, the source should be identified if possible in order to identify patients who may benefit from a timely and effective intervention. For example, percutaneous or surgical drainage. Conditions that may benefit from early intervention include removal of infected vascular access device, example, central venous catheter, urinary Foley's catheter, etc. Anything can be removed, just remove it if you are thinking about it. Percutaneous or surgical drainage of deep space infection like intra-abdominal, intrathoracic, intracranial abscess, joint space infection, necrotizing skin, and soft tissue infection. Don't be satisfied with a diagnosis of sepsis and no source. So believe me, you didn't do your job if you didn't find the source. If a source exists and is potentially removable, get the ball rolling. What a prognosis and outcome of sepsis? I will let you with this. Okay, so it's very bad disease. It's very bad situation. The mortality is very high. Unfortunately, it's for the sepsis alone, it's reached to 50% of the patient. For the septic shock can reach about 80%. So if we have a patient with sepsis, make sure we don't have organ failure, because the more severe sepsis, the more organ failure, and eventually more mortality. And unfortunately, with all of these importance and all of this work, all of these campaigns, all of these criteria, everything we did for the sepsis and septic shock, still the incidence increasing and it's high, as well as mortality. Unfortunately, we can say we did a good job by reduction, 17% reduction in mortality, but it's not the good number what we are looking for. However, inshallah, with your careful and your further I encourage all of us to be more keen to our patient, to be more responsible, and I'm sure that we will do a great job, inshallah. I wish I did a great and fruitful lecture today and presentation. I added something to you, and sorry if I did, if I had any bad or any mistakes. Thank you so much.
Thank you, Dr. Ala. We like your presentation, especially the interactive part and the video. And maybe later we will, you will have to give us a presentation how to make this presentation. Okay.
I really appreciate, and I thought that from you, Dr. Ahmed. Thank you so much.
We have a question here. Do you think there is a role for dialytic therapy in removal of endotoxins and cytokines and help in the management of shock?
Actually, till now, nothing supports that. But I believe that maybe in some situations we can use the plasmapheresis. Maybe we can do some help for the patient with the plasmapheresis, but not diuretic, unfortunately.
With some studies, they talk about CRRT or continuous renal replacement therapy in the form of continuous veno-venous hemodiafiltration. If we increase the dose of filtration and remove the water content of the blood and replace it with a substitute clean and out of all this, as you mentioned, there is no supportive studies right now, but previously they were supporting that this may remove some of the toxins, regardless the nature, whether cytokines or endotoxins or like this. But in the same time, we are removing the antibiotics.
This is the problem. Yeah, the antibiotics, usually we are afraid if put the patient on any type of renal dialysis. We are afraid that the antibiotics will not last long in the blood, and it's equal to you didn't give that antibiotics. So we need to make sure that antibiotics given after the dialysis and last for some quite a time.
So thank you. I like the presentation very much, and it was very informative. And especially the video part we like, because this is the first time to see something like this in our symposium. So thank you, Dr. Ala, and I hope we can share this presentation again internally inside our hospital.
Definitely. This is my pleasure, and I honored that I am part of this is a great company, and inshallah we will do a great job, inshallah.
Thank you, sir. I would like to ask you to stop sharing your screen, please.
Sure.
Thank you. And now, with the next session, we finished the first session, and this is the next session, second session today. We'll start with Dr. Abdul Aziz Al Abdul Ali, consultant hematologist, and he will talk to us about new oral anticoagulants.
Thank you, Dr. Ahmed, the organizing committee, for inviting me for this great symposium. It's my pleasure to present this talk. Also, I'd like to thank the audience, and I look for your comments, questions, queries at the end of the presentation. So let's get started. Direct oral anticoagulants. I have no disclosures. As an introduction, I hope at the end of this presentation we'll be able to identify for clear the indications, contraindications, and cautions of direct oral anticoagulants, to differentiate dosing by indication and comorbidities the patients they have, to be aware of drug and drugs interactions, which do exist, and to look at how to monitor if there is any laboratory monitoring tests, and how to reverse the effect, and how to take care of patients peri-procedure management together of how to approach a bleeding patient on drug. The fact is that most of our patients are not the straightforward types of patients. So physicians and healthcare workers try to find a drug that is more or less straightforward. You can give one dose to all patients. It's an ease of mind. Single pill, it's one dose, all patients and all indications, no interactions, no need for INR lab monitoring, with hopefully increased compliance. But this seems to be, with time since 2010, more or less like a myth by pharmaceutical representatives. I'll show you some facts. Quick cases. 68 years old female, diabetic, hypertensive, recently diagnosed with atrial fibrillation. She was started on rivaroxaban, usual dose, 20 milligram daily. The patient is taking it on an empty stomach. And this is the clue. 30 days later, she developed right-sided weakness, brought to the emergency room. CT scan as part of the workup showed left MCA infarct. She should take it on a full stomach, i.e. after food. Another elderly female, hypertensive, diabetic, lipids. She lives in a nursery home. 2 weeks ago, diagnosed with atrial fibrillation. Started on dabigatran. It's a clear indication. But due to swallowing difficulty, the nurse is crushing the drug. 14 days later, she was non-responsive. Massive intracranial hemorrhage. Dabigatran shouldn't be crushed. 70 years old gentleman, atrial fibrillation since 1 year ago, with previous history of TIA, hypertension, just started last year on AID-WAC, which he was very compliant with it. 2 weeks ago, complained of epigastric pains, found to have H. pylori, started on triple therapy. Class C was included in this triple therapy. 10 days later, came to the emergency room with severe GI bleeding, hemoglobin of 5. So yes, there are DWAC medications interaction. And the seriousness is that we cannot monitor it. Like warfarin. This is another elderly female, diabetic, insulin, hypertensive, new onset atrial fibrillation. She was started on AID-WAC and verapamil. 10 days later, came to the emergency room with melena and anemia. There is a significant drug to drug interaction. Again, cannot monitor it. In the majority of atrial fibrillation patients, you will find them on a medication like verapamil. This is another elderly farmer, hypertensive, high lipids. Creatinine was just abnormal. Lives outside Riyadh, 10 months ago, diagnosed with atrial fibrillation, started on a DWAC with just refills during clinic visits. He came with progressive weakness, shortness of breath, palpitation over 2 months. Clinically looks in distress, pale, hypotensive, tachycardic, and the workup included a creatinine of 4 and anemia. He should be monitored with CBC, liver, and creatinine measurements at least every 3 months. He developed high creatinine. He failed to clear his DWAC, so he bled. Young female, severe epigastric pain, history of small joint arthritis. Workup included CT, showed portal mesenteric vein thrombosis. White count was 5, but she's lymphopenic, anemic, microcytic anemia with very mild low platelet and high ESR. She was started on Xelerto, 20 milligram once a day. Pain continued, and 4 days later, chest pain, hypotensive, hypoxemic, had to be admitted to the ICU with intubation. Investigation showed bilateral pulmonary embolism. The clue here is small joint arthritis. Hypercoagulable patients, especially with antiphospholipid syndrome, shouldn't receive DWACs. Again, elderly, diabetic, hypertensive with lipids, atrial fibrillation. He was on DWAC since 1 year, presented to the emergency room with right-sided weakness. Workup confirmed left MCA, ischemic infarct, without hemorrhage. He had normal CBC, INR, creatinine. So, if the old criteria or inclusion criteria for thrombolytics in ischemic strokes are applied, where they look at the normal INR, and this patient had, he was given thrombolytics, but the next day, he developed massive hemorrhage. So the DWACs do not affect INR, and you should be very careful for applying thrombolytics for such patients. If you have to, you need to follow the updated criteria for giving thrombolytics in such a situation where patients are receiving DWACs rather than warfarin. Multiple anticoagulants we are using to treat clotting disorders, but here we will just concentrate on the new oral anticoagulants. 4 of them are anti-10A inhibitors: rivaroxaban, apixaban, edoxaban, and trixaban, and 1 direct thrombin inhibitor, which is dabigatran. Anticoagulation started in the early 19th century and up until 2010, where we start having these new oral anticoagulants or direct oral anticoagulants, namely the most famous ones, the 4 of them: dabigatran, rivaroxaban, apixaban, edoxaban. These are some of the concepts or beliefs since 2010 that I can say that I was led to think that DWACs are superior in efficacy to vitamin K antagonists, all of them, and in safety. They're much easier to handle than vitamin K antagonists, have no drug interactions, safe in renal and liver, have 1 dose that fits all, leads to better patients' compliance, not requiring follow-up testing. And you can start it even without the presence of or availability of an antidote, which would make anticoagulation far much easier than before. These turned out to be really a myth. Anticoagulants in general, extensively used in clinical practice. Each and every specialty are using it. They target different number of proteins to prevent thrombosis. Problem, they are high alert, i.e. they have narrow therapeutic index. Over or under anticoagulation can result in significant adverse events. Choice of the anticoagulant will be based on a variety of factors and indications. And up until the introduction of drugs, we used to have only warfarin. Regarding adverse events, it's very common with anticoagulants, and this data is very important to show you that 48% of medications error in hospital are related to anticoagulants. In the emergency room, elderly patients' visits because of adverse drug events, the major cause is anticoagulants. This constitutes 17.6%. And you have to admit 50% of these. Look at this with drugs. This data that looked at 5,700 patients on drugs, looking at the dose that they are receiving, whether it is prescribed right or wrong off label. 9% they were underdosed, not receiving the right dose. 3% overdose. This is a total of 12.8%. And this translated clinically to serious outcomes in terms of bleeding, stroke and systemic embolization, MI, hospitalization, and all-cause mortality. In Saudi Arabia, we have the 4 medications. Dabigatran is the dates of approval, Apixaban, Rivaroxaban, and Rituxaban. Dabigatran, Apixaban, they are taken as a BID, while Rivaroxaban, Rituxaban as once a day. With Dabigatran and Rituxaban in deep vein thrombosis, you have to start with parenteral anticoagulation before you switch to these 2 medications. Very important information to the patients. Dabigatran should not be chewed. Rivaroxaban is very serious issue also. The 10 milligram can be taken with or without food. The 15 and 20 must be taken with food. Shouldn't be taken on an empty stomach. Otherwise, it won't be absorbed. Regarding the absorption and metabolism of this medication, just in summary, 5 points that I like to share with you. First of all, they are absorbed from the GI with the help of the glycoprotein. And what it does, it facilitates the absorption and at the same time excretion in the intestinal lumen until it reaches steady state. So inhibitors will stop the excretion. This will lead to accumulation and toxicity of the medication. These inhibitors, the best example, verapamil, Nidoron, quinine. All these medications are used in the elderly with atrial fibrillation. The second point is that they are metabolized in the liver. The least is dabigatran as opposed to the other 3. The third point, renal excretion. Dabigatran mostly is renally metabolized and excreted by the kidney, so it is the most affected by renal impairment, as opposed to Apixaban, which is the least usually excreted unchanged. Last point is the interaction with food, and this is very significant with Rivaroxaban at high doses, the 15 and the 20 milligram. Other just forgotten side effects, other than the bleeding, which is very common or logic with any anticoagulants, is dabigatran is very nasty on the the GI in terms of nausea, dyspepsia, gastritis, abdominal pain, and a significant number of patients, they stop using or continuing the medication. The problem is that you wouldn't know that you don't have a testing, laboratory testing for it, that you keep checking in the clinic, like the INR. What's peculiar for rivaroxaban is the skin, edema, itching, blisters, and muscle spasms. All of them, they can affect the liver. In addition, apixaban, thrombocytopenia. Always monitor renal, liver, and CBC. Renal, it should be as per recommendation, at least every 3 months. This is the coagulation cascade, simplified one, looking at all these medications. Warfarin works on factor 2, 7, 9, and 10, and we follow it with INR. The anti-10As, they're working at activated 10A, dabigatran on thrombin, it's an antithrombin. So what they do with our current laboratory tests, they affect the BT and BTT, but they cannot be, it's in a random fashion. We cannot use these tests for assessment. Rivaroxaban does affect BT more. They don't have an effect on thrombin time and activated clotting time. You can use anti-10A to measure the DWACs, but the anti-10A DWACs. But you have a special calibrators. They're totally different from low molecular weight heparin calibrators. You need to check with your lab. So hardly you find in any hospital or setting thrombin time, activated clotting time, or Icarin time. Let me show you the bottom line here. Forget BT in the setting of DWACs. Regarding BTT, a normal BTT does not exclude on therapy level, but it excludes above therapy level. So if you think a patient is overdosed and his BTT is normal, then he's not overdosed. Thrombin time is very helpful. A normal thrombin time excludes even very low level, but it's not good for therapeutic levels. So these two tests in a setting, let's say, of a bleeding or thrombotic patient on DWAC coming to the emergency room do help you in this regard. Dilute thrombin time, Icarin time, activated clotting time, they are much more specific for measurement of the levels in the therapeutic range. Last but not the least is specific drug level, and this is nearly or in a very highly sophisticated laboratories. So what are the times that you may need to do these measurements or the definitive DWAC measurements? In the setting of emergency, where the patient is bleeding, urgent procedures, acute stroke, it helps the clinician on recent exposure. Uncover associated bleeding disorders, because if you get a level which is below the normal, then this will help you in trying to figure out other causes for bleeding in this patient and dealing with them. It can help in timing of whatever emergency procedure. What about measurements before elective procedures? The recommendation is not to do that, but this can be considered when the intake is uncertain or concerned about impaired blood clearance, like in renal impairment or liver disease. What about monitoring during long-term exposure? Again, it's not recommended, except if there are situations where the pharmacokinetics are not well studied, like very obese, uncontrolled cancer, drug interactions. But in this situation, the international recommendations is to use a non-DWAC drug rather than a DWAC. Before we start any DWAC, look at the contraindications. It shouldn't be used in pregnancy, lactation, under 18 years, severe sensitivity, prosthetic heart valves, mechanical heart valves, active pathological bleeding, acute kidney disease, dialysis. Except recently, the FDA have approved the apixaban for this setting. Chronic kidney disease based on the creatinine clearance. And you can see apixaban has the lowest creatinine clearance that you can use as opposed to the others, as we said before. Shouldn't be used in advanced liver impairment or pulmonary embolism where there is instability or you attempting thrombolysis or embolectomy. Hypercoagulable states, especially antiphospholipid syndrome, and or homozygosity or inherited disorders. What about the different indications? Let's just summarize the FDA and two societies, the American Society of Hematology and the ASCO, American Society of Clinical Oncology indications. All of them are indicated in atrial fibrillation, non-valvular atrial fibrillation. All of them indicated for DVT-PE treatment and extended prophylaxis. And total hip and total knee, except dabigatran, it's only in hip. This is a very important point to remember, that VTE prevention after hip fracture, none of these is indicated by FDA. So you have to be careful, still low molecular weight heparin. Acute coronary syndrome, it's only the rivaroxaban. And of course, the low molecular weight heparins. Mechanical valves, low molecular weight heparins, warfarin. The cancer, prophylaxis. Low molecular weight heparin are the most important agents. Edoxaban, rivaroxaban can be used, but this is not an FDA. This is these societies' recommendations. The treatment of VTE in cancer, low molecular weight heparin, or rivaroxaban, apixaban. Again, these two drugs are not FDA approved. Medically ill patients, that's including the ICU, low molecular weight heparin. No approval for the drugs. This slide is so busy, but the message is for any given indication, you have different doses for each drug medication. You have to know this before prescribing it. It's not only that. Within each medication, there are some drug adjustments that need to be done based either on age, weight, creatinine clearance, and to inform the patient whether to take it with or without food. Whether you need to take or to give your patients parenteral therapy before starting it or without. The problem, if we don't adhere to these, the side effects of these high alert medications are more likely to happen, since simply we are not measuring the level, or we don't have a lab test like INR, what we do with warfarin. So always the issue of these drugs, they make or they increase the compliance of patients. And actually, this is a myth. Look at this data from a Dutch foundation, where they look at a high number of patients, whether on DWAC or vitamin K. And at 2 months, 20% of those taking DWAC, they stopped taking medication. And you wouldn't know about it. You don't have an INR test for it. While vitamin K, 9% they stopped it. But you will know that, and you will be able to counsel your patient. So hopefully he or she will correct this compliance issue. The other point, even among the DWAC pharmaceutical company representatives, they may tell you one drug, one pill a day is better than 2 pills a day. Like rivaroxaban is better than apixaban. And look at the steady state of 2 medications. One is taken twice in red or once in blue. This is the normal state. What about if you missed a BID dose? Look at the level. Yes, it goes down, turns back. Not a prolonged interval. But what about missing one once-a-day pill? It is equal to missing 3 BID doses. That's very significant. In a high thrombotic situation, patient can clot. The same thing if you take one extra medication of either the BID or the once. See how bleeding can happen with the once daily dose. Some practical issues. When your patient is on DWAC and you want to put him on parenteral anticoagulants, so when the next dose of the DWAC would be due, just switch to the parenteral medication. And vice versa. He's on parenteral and you want to go to DWAC for unfractionated heparin, give the DWAC 2 to 4 hours with the low molecular weight heparin. At the time of the next dose of it, switch it to a DWAC. What about over and underweight patients, which are less than 50 kg or more than 100? They are underrepresented in the clinical trials. So if DWAC is decided in such patients, the recommendation is to do assessment of plasma trough for these patients, which is extremely unpractical. So these patients should be on warfarin. What about food, antacid, NG tube administration? We mentioned that rivaroxaban, the higher doses, the 15 and 20, should be with food. The 10 can be either or. No other interaction with food with other DWACs. It is safe to use PPIs, H2 blockers, or antacids. There's no data on fish oil supplements, which lots of patients with AFib are on. Crushing shouldn't be done with dabigatran, but it can be with apixaban, rivaroxaban, edoxaban, and even in solutions and given via NG tube. What about dosing error that the patient should be informed about? Missing a dose. It can be taken until 50% of the dosing interval has passed. After this point, the missed dose is kept unless he's high risk or she is high risk for thrombosis with low bleeding risk. What about taking a double dose? If it's a BID medication, skip the next dose. If it's a once a day, continue without skipping the next dose. What about if he or she's uncertain of taking the dose? Again, for BID, do not take another dose. For once a day, take another dose if CHA2DS VASC is more than 3. And don't take it if it is less than 2. And we'll come to this scoring system later on. For kidney, busy slide. I keep it just to remember when I face patients. But a few points is that you look at apixaban is the most safest out of all of them. And we said that it gets secreted in the kidney unmetabolized. And we just have FDA approval using it in patients on dialysis. Edoxaban, you have to be careful when the creatinine clearance is more than 100. The level is very high and it's unadvisable to use it. The other two medications, can be used within these creatinine clearance levels, mind you, with still adjustment for dosages, keeping in mind the effect of weight, age of the patient. Liver, these are the recommendations that severe or advanced liver disease patients should not receive drugs. You should be cautious with child B. What about drug interactions? We talked about strong inhibitors. Mostly they are azoles or the HIV. We shouldn't combine them with DWAC or DWAC with them. Strong inhibitors of both P-glycoprotein and CYP3A, azoles, and the HIV. The other category is to avoid using oral anticoagulants or the direct oral anticoagulants with the moderate inhibitors like this list, or inducers, strong inducers of P-glycoprotein, or inducers of CYP3A4. It's a very extensive list of medications. Most of them, I'm sure that you are facing lots of your patients on them. And these lists, you can access them. And the best method I found, because the information is always updated, you cannot stick yourself to just one list, but rather to keep checking each and every medication every time for each and every patient. It's time consuming, but it's worth it. It's worth it. Now, so your patient is planned for an intervention, surgical or radiological, and he or she is on DWAC. The steps to take in this situation is, first of all, assess the patient's risk of thrombosis, follow it by assessing the risk of bleeding. And the risk of thrombosis, it is dependent on the indication, where patients are categorized into high, moderate, or low risk, based on whatever indication for anticoagulation they have. The bleeding risk depends on the procedure. And again, there's an extensive list of minor risk patient procedures, low risk or high risk by different specialties. Now, for those who are having minor surgery, usually not to interrupt anticoagulation, as we do with warfarin. Another approach is to hold only just one dose if the patient is not high risk thrombosis. What about moderate bleeding or high bleeding? The point is to stop 2 days prior, except the bigatran 3 days if creatinine clearance 30 to 49 for moderate bleeding risk. For high risk, it's not 2 days, no, 3 days, with 5 days for lower creatinine dabigatran. When to resume moderate bleeding risk, the next day. High bleeding risk, 2 to 3 days after the procedures. And you're faced with a bleeding while using a DWAC or NWAC. Usually we categorize them into mild, or non-life-threatening, or life-threatening. In the mild bleeding, we just delay or discontinue the next dose. Think of other medications the patient is having. Mostly they are on antiplatelets, non-steroidals. So you can adjust these and rethink of reusing the DWAC in this patient. In the non-life-threatening major bleed, concentrate on mechanical compression, endoscopic hemostasis of gastrointestinal bleed, surgical hemostasis, fluid replacement, red and platelet substitution. You may use with caution tranexamic acid for a short time. Maintain adequate diuresis. They are hypotensive, they bleed, so you don't need an additional renal cause for drug accumulation. For dabigatran, it has this antidote. Hemodialysis can be also done. Life-threatening, more or less the same, but most of the time you need the antidote, the specific antidote. Either oxazumab for dabigatran and adnexate, which is now approved by FDA for the anti-10As medications. We can use prothrombin complex concentrate or the activated one. So for these patients, stop the DWAC, stratify bleeding severity, obtain history of last DWAC intake. As we said, these are general lab tests that will help in assessing the patient. PTT thrombin are helpful. Do your best to mechanically stop the bleeding and supportive measure with or without the reversal agents. Let's go to atrial fibrillation, which is a very common clinical scenario that we see everyone is facing. With it, the stroke is increased. And also the type of stroke that is happening with atrial fibrillation seems to be worse than a stroke caused by other causes in terms of mortality and dependency. So any patient with a history of atrial fibrillation should be risk assessed for stroke and bleeding risks. Then appropriate antithrombotic therapy is indicated. This is just some history. Before aspirin was used to reduce the stroke by 22%, but warfarin is more superior to aspirin alone, 1.8 as opposed to 3.8% annual stroke. This is the BAFTA study. Warfarin is more superior to aspirin plus clopidogrel. Aspirin and clopidogrel is more effective than aspirin alone, but results in more bleeding. What about the ACCP 2018 guidelines? They stated that each and every patient with AFib should be assessed for stroke risk by SHA-2DS2 VASC score, not the old score. I'll show you a slide about this. Those with low risk shouldn't be anticoagulated. Low risk, by definition, age less than 65, irrespective of age of 6. Those with a score of 2 in a female or 1 in a male, they should be offered oral anticoagulation. And they are against antiplatelet alone, monotherapy, or aspirin with clopidogrel and the prevention of stroke. So what is their recommendation? They, in the ACP 2018, they stated that we recommend NWAC over vitamin K antagonist. In patients with vitamin K with consistently low time in INR, which is time in therapeutic range, less than 65 of the times, they recommend intervention to improve this or switch to NWAC. In patients with prior unprovoked bleeding, warfarin-associated bleeding, or at high risk of bleeding, we suggest using apixaban, doxaban, or dabigatran, 110, not the 150, because the 150 and the rivaroxaban GI bleeding is as worse as warfarin. Now, this is another European recommendation, which is the European Heart Rhythm Association. Heart and Rhythm Association. And they expressed a preference for NOAC over vitamin K antagonist in stroke, especially if newly initiated. So what is the CHAT2 DS2 VASC score? It has 8 factors, total score of 9. 0 is low, 1 intermediate, more than 2 is high. The previous one is CHAT's 2 score, which is 5 factors as opposed to 8 factors. Why it is recommended to use the new CHAT2 DS2 VASC score is highlighted by this example. It's supposed if a 70 years old female, history of MI, by CHAT2 CHAT2 score, she's 0. But by the new score, she's 3. So she should be offered oral anticoagulation. And what that means practically or clinically is that 64% of 0 and 1 risk patients assessed by CHAT's 2 score will be upgraded to 2, and they will need oral anticoagulation. Has bled. Seven variables. And based on this score, whether they are low, intermediate, or high, and this is the chance of their annual major bleeding risk or intracerebral hemorrhage risk. So putting these 2, you would be able to counsel your patient about her risk of thrombosis or embolic stroke and bleeding. These are the definitions of the has bled factors. So to make things easy, 3 questions when you are faced with a patient with a non-valvular atrial fibrillation. Is the patient more than 75? If the answer is yes, he or she qualifies for oral anticoagulation. This is the first step. If less than 75, if there is a history of TIA, stroke, or embolism, then qualifies. There is no such history, then you try to find any one of the following: age 65 to 74, hypertension, vascular disease, defined as MI, peripheral artery disease, or aortic plaque. And I'm not sure how many of us are looking for aortic plaques in these patients. If the answer is yes, offer oral anticoagulation. If no, they don't qualify for it. So this is the first step. We assess the stroke risk. Slow, no anticoagulation. If it's moderate or high, determine bleeding risk. Low risk of bleeding, we go to the step of oral anticoagulation or vitamin K. If the bleeding is high, we try to modify whatever bleeding risk patients are having. So let us now go to whether to choose DWAC or vitamin K. And if we choose DWAC, which DWAC? So a quick look at the main 4 trials for DWACs in non-valvular atrial fibrillation. We have the Aristotle for apixaban, Rocket AF for rivaroxaban, dabigatran, Rely, doxaban, Engage. Now, the most important point is that all of them, the design was non-inferiority. It was not, they were not looking for superiority, but with a planned subsequent analysis, superiority analysis, if they found that they are non-inferior. The bottom line is apixaban is superior in terms of preventing stroke. The same thing as dabigatran 150 milligram. Rivaroxaban is not superior. nor Doxaban. All right. What about the safety, which is the bleeding? Apixaban is superior to warfarin in major bleeding. The same thing as Doxaban. But rivaroxaban and dabigatran 150, they're not superior. So from this, one would choose someone which is superior in efficacy and also superior in safety, which is apixaban. Now, it's very difficult to compare results from one study to another study, but this paper, I find it extremely helpful, which is looking at the clinical endpoints, which is the stroke, ischemic events, bleeding, the stroke, whether it is ischemic or it's a bleeding, and the mortality. And they give a weight for each and every event. An example, a hemorrhagic stroke is worse than an ischemic stroke or embolism. And they looked at all these 4 medications, and all the events, in addition to the cardiovascular mortality, see the benefit. Dabigatran, 10% benefit. And if you add all-cause mortality, still 9%. But look at, for example, apixaban, 19% in preventing these events, and the cardiovascular mortality, 17 all-cause mortality. So it has the best clinical effect profile, as opposed, let's say, for rivaroxaban. Similar to warfarin when it comes to the events and cardiovascular mortality. But when you add all-cause mortality, yes, it gives you a 10% gain. I'll skip this for the sake of time. Be aware of, you would find in the literature lots of suggestions based on whatever patient criteria. I will prefer this DWAC over the other DWAC. There all seems to be non-scientific societies recommendations. But I think with time they will have some rule, but be careful of relying on them. DVTBE, ACCB, the most recent, they were suggesting DWACs, all of them, over vitamin K antagonists. And this is based on less bleeding, greater convenience. The strange thing, it's very valid for patients, but for healthcare providers, and very strange statement for me, I find it. And they stated there's no one DWAC is preferred over the other one. But look, this is a summary of the efficacy. All of them, they are non-inferior to warfarin. So it's fair. No one is better than warfarin. But bleeding in the setting of DVTBE, all of them are similar, except apixaban is significantly less. So one would think or would suggest using a similar drug to warfarin, but with significantly less bleeding risk. This is thromboprophylaxis in hospitalized medically ill patients. Still the recommendation, most recent until 2020, low molecular weight heparins, not direct oral anticoagulant. Now, hip-borne ear arthroplasty, this is the orthopedic situation. DWACs are dominating now, the low molecular weight heparins, but in the hip fracture, still the low molecular weight heparins. There's no place for DWACs in this setup. So, this last point, anticoagulants are extremely high-risk medications. The anticoagulation process is becoming more complicated, especially by the introduction of the drugs, leading to a higher patient's risk. The message that I really like to deliver through this presentation is to have a constructed multidisciplinary anticoagulation service for these patients in your institution. This will help your patients. It will make your practice much more safe. Thank you.
Thanks to our Professor Dr. Abdulaziz for this nice presentation, and it seems that we have some questions. We will try to summarize from where to start. It seems that you have some fans. Many questions.
Most welcome. Which ones you want?
I need this lecture, Dr. Abdulali, in a video format. Okay, sir, Dr. Mushabab, inshallah, we will do our best for this.
It costs 10 riyals.
10,000. For how long could Blavix be used? And could it be in companion with aspirin and or warfarin? If so, this together been together for infinity? And could be Blavix by E used as prevention?
Okay, if we're talking about non-valvular atrial fibrillation, the recommendation is not to use antiplatelets, whether it is aspirin alone or aspirin with another antiplatelet, but to go with oral anticoagulation if the risk of embolism, systemic embolism, is judged to be 2 or more by the scoring system.
Is apixaban FDA approved in dialysis?
Yes, it is.
Docs in antiphospholipid without history of thrombosis?
Usually antiphospholipids, we don't anticoagulate them unless they have a VTE or arterial event. So if your question, you have antiphospholipid syndrome patients who's not having thrombosis, never had thrombosis, we don't anticoagulate that patient. But if he or she developed thrombosis, now it's a warning or contraindication to use wax in this setting, but rather to use low molecular weight heparins and warfarin. In addition, there is a strong recommendation to apply this for patients with major thrombophilia. And what we define these major thrombophilias as homozygosity for factor V Leiden, the protein CS deficiency, and 83. These are considered major.
Actually, questions of your fan, Dr. Mushabab, is asking about aspirin resistance and the role of aspirin in atrial fibrillation, and if atrial fibrillation was platelet less than 140, what measure shall I do as a primary care, and what is the role of primary care in antiphospholipid, and what is the role of primary care in thrombotic events?
Okay, so Dr. Mushabab, mashallah, it looks that
he took
this discussion with you is extremely interesting, and we can talk a lot about so many things, especially in the primary care setup.
The problem, we have to be sorry for Dr. Afaf.
No, it's okay. So
it's okay.
We can later on discuss with Dr. Mushabab, the primary care anticoagulation, which is extremely extensive, interesting field. So we'll have later on time for it. Please.
Okay. Do you think there's any other question? Family doctor role in management and their mode? Any difference? Is there difference? Is there any differences in NOx?
Yes, it is. Yes, it is. There are differences in WOX according to ethnic diversities. Usually, Asians and Southeast Asians are clear. They need less dose than Caucasians.
Okay, so this will be the end of our lovely presentation, and for the questions that was not answered, I would like to tell the doctors who raised these questions that Dr. Abdulaziz will write down the answers, and it will be here on the Zoom, so everyone can read the answers, and in the same time, he can answer the same question on the YouTube channel of the presentation. And now for the time, I'm very, very sorry on behalf of the organizing committee that we took a long time, but really, really, it was interesting, and it really make a benefit to all of us to hear from Dr. Abdulaziz. And in the same time, we can't wait to start with Dr. Afaf Al-Shammari. We are happy to have Dr. Afaf here with us. I'm really sorry, Dr. Afaf, and I am really happy that you withstand us and you're staying till now with us.
It's okay.
Dr. Afaf today will talk to us about two presentations. The first one will be obesity, pharmacotherapy, and the second one will be about diabetes and aging. Dr. Afaf is a consultant endocrinologist and the president of Saudi Society of Endocrine and Metabolism. We are very happy that you join us, Dr. Afaf, and let's see what we can do.
Okay, is these slides clear for you or no?
No, you have to press share screen.
Yeah, I'm trying to.
You will find an icon of share screen, green light.
Yeah, sure.
Down, yeah.
Okay. Now, is it clear?
Yes, it's clear, but you didn't choose the starting one.
Yeah, okay, sure. So I'll just make this minimized. Okay. Thank you very much, Dr. Ahmed, for the nice introduction and invitation to this meeting. Today, is the voice clear?
Yes, everything is clear. We can see the slides and we can see you, and
Sure.
your voice is really clear.
Thank you. They asked me to present or the shared with the metabolism or obesity in this prestigious conference about the internal medicine. So I'm going to talk today about the pharmacology or pharmacotherapy for the obesity. Are they effective, or do we have, what are the treatment that we're having in the market up to now? So the obesity is the potential life-threatening chronic disease as the most prevalent metabolic disorder affecting the human, and the obesity require multidisciplinary long-term treatment. The first thing we just to have an idea about the classifications of the obesity is based on the BMI, and with the BMI, when we make the classifications, not only the number, but it has to be on regard of the risk assessment. Are they at high risk or mild risk, or they're normal with no risk? So the BMI, if it's less than 25, which is up to 24.5, is we call it is normal BMI, and there is no risk related to the disease itself. While when we start from 25, we start to have a risk, and it's subsequently been increased based on the increment of BMI. So when we have it like up to 29.9, less than 30, this is overweight, and we consider it high risk. More than 30 is the, now we start with the 30 and above, this is obesity classifications, and this is super high. 35 to 40, it is the class 2 obesity and super high. And more than 40%, it's a class 3 obesity, and this is established disease. How can the obesity will affect the risk factor, or why the obesity is a disease when we talk about this like a disease? So it's here the access at obesity lead to major risk factors and common chronic diseases. Here, when we have obesity is being increased, you can follow me on the left side of the slides, is the adipokines synthesis increase, and this will affect the increase in macrophages and other inflammatory cells, and this is pro-inflammatory cytokines, and this will affect impaired insulin signaling and insulin resistance, and subsequently, this will lead to type 2 diabetes. The other thing, when we have increased obesity, we'll have increased lipido production, hydrolysis of triglycerides, and release of fatty acids. And when we have release of fatty acids, we have both of two pathways. One will cause lipotoxicity, and this will affect the liver mainly, and NAFLD and NASH, and end up with the cirrhosis. And the other thing, even for lipotoxicity, can go for the heart disease and the CKDs. And if we have it in dyslipidemia, this will cause heart disease, and subsequently will go causing congestive heart failure, stroke, the microvascular complications or microvascular complications, CKDs, and the same as type 2 diabetes could cause this problem. And here, when we have the increased weight, is the increased activity of sympathetic nervous system, and this will cause, with the increased activity of renin, angiotensin, aldosterone system, this will make more vasoconstrictions and the systemic and pulmonary hypertension. And with the mechanical, when we have the stress, with the pharyngeal soft tissue, obstructive sleep apnea, and the joint osteoarthritis, intra-abdominal pressure can be GERD, and the GERD, we know the complications of GERD could have Barrett esophagus or adenocarcinoma. Here, if we want to summarize this, the multiple comorbidities with the obesity, we can go is like divided in metabolic, as NAFLD, gallstones, infertility, cardiovascular, stroke, dyslipidemia, hypertension, coronary artery disease, and the restrictive ejection fraction, and heart failure, type 2 diabetes. And when we have it mechanical, we could have it like asthma, physical functioning, affecting incontinence, knee osteoarthritis. And when we have it like mental, depression, and anxiety, these mainly the things that could associated with the obesity. Does this affect the life expectancy? Because in the previous two slides, we talk about the risk associated with the obesity, which is the quality of life could be affected, and the risk can develop with the obesity. What about life expectancy? Here we have it, when we see the graph, is with the gray color normal BMI with almost 80% chance of reaching 70 years old. So we can see it here, 70 years old, when you count the graph, is almost 80% can reach if they have normal BMI. While here with light blue, when we have it, it's around 60% of the people with BMI between 35 and 40 reach 70 years old. And if they are with the morbid obesity, with a BMI more than 40 to 50, it's the 50% here chance of the people with this BMI could reach 70. So it does affect the life expectancy, whether directly or indirectly because of the complications or the risk factors being associated with obesity. So what is the primary purpose of the medication used in obesity treatment? Why we should treat? Is the things is being published in Circulation 2014. The rationale for the use medication is to help patients adhere to a lower calorie diet more consistently in order to achieve more sufficient weight loss and health improvement when combined with increased physical activity. So what is the model to use in patients with the obesity? It actually is being divided, and because when someone is coming to the clinic, because most patients would go with the pathway. I'm not talking about the fancy things that is being done, or the things is being done and multiple, or the people they are pushing to go for surgery. But when you go with the guidelines and who are the cases that we take the pathway for surgery and who could get benefits from medical treatment, which is the based on the BMI, and as we mentioned, BMI and the rest, because if we have the more than 25, but it's still less than 27, we can go with the lifestyle modifications and expected the weight loss 4 to 8% could lose weight. If they are having 27 BMI with 2 comorbidities or more than 30 without comorbidities, the treatment is not only lifestyle modifications, but we have to add pharmacotherapy. Pharmacotherapy, we're expecting to lose weight between 5 to 12 from the initial weight. And we can use multiple, I'm going to talk about it later on, like orlistat, phentermine, naloxone, and liraglutide can be used. If a patient is having more than 30 BMI, more than 35 BMI with 2 comorbidities, or more than 40, I think is beside the lifestyle, and the pharmacotherapy will not be effective in those with morbid obesity. It will be very difficult to lose or to maintain later on. So could go for obesity surgery. I can assure you a lot of the things that happened for the last decades, they are not following the guidelines, and people, you can see them here and there, they are pushing for surgery. And the surgery expected to lose the weight between 14 to 33 of initial weight, whatever is the kind of surgery, whether band or the Rowan Y or any kind of sleeve, any kind of the surgery that we can have. What about the drugs? That is the main concept of our presentation today being used, is the mechanism of action with all the drugs that's been available in the market. Some of them being approved, something they are waiting on the line to be approved, some is being disapproved, taken from the market, or something that has been used but not approved by the any authorization, international authorization, or it could be authorized in some of the, like Asian in Japan, or it's not approved in some cities. The main concept of those medications is whether to work in central here on the brain with the hunger center, or some of them they can work peripheral, or some they are both. So when we talk about like lorcaserin, naltrexone, or phentermine, all are central. When we talk about orlistat, Zanical that is in the market is mainly GI and its stomach and intestine, so it's peripheral. The only one can combine is central and peripheral is liraglutide, which is GLP-1, because can work through the hunger center, suppression of the hunger centrally, and affecting the stomach emptying peripherally. Here is a long list that is being was in the market or been taken off. So orlistat, you can see, is being approved by EMA, FDA, and Zaypan, and we have Contrave, which is a combination of naltrexone, and we have topramide, and all this is being used for the obesity. We have Xemia, which is phentermine topramide. We have the sibutramine, and we have the lorcaserin. We have liraglutide. We have empagliflozin still in phase 1, not been approved. But what are the long-term use? Is the still we are using the anti-obesity that can be safe, because its safety and efficacy, these are with any used in the market for any kind of disease. So what about the obesity? Because do we use it? If we use it, is there any risk for that? What is the mechanism of actions, and for how long? What is expectations to lose weight? So here is basically, these are now available in the market and still being approved with no big concern. So when we talk about Aristat, Zenica, or Aristat, the other one, Ally, so the Aristat has been approved in 1999 and fat blocker, and we have phentermine topramide, which is combination, because amphetamine derivatives, anti-seizure drug, it was in 2013. We have naltrexone, the propranolol, Contrave is 2014, opioid antagonist and antidepressant, and we have liraglutide 2014 is GLP-1. I'm going to talk about each one separately. So when we talk about Aristat, what is the Aristat? It's been approved in, as I mentioned, 1999, and today it remains the longest licensed anti-obesity drug for long-term use and is available over the counter because it means it's been safe, it's been used. Efficacy, you have, well, you can go with the studies and how much expectations patient will lose when they use the Aristat. But the most important thing is being safe, and the duration of released, since being released, this is assuring, and it is non-central nervous system agent. Aristat can be used 120 milligram and prescribed for adult or adolescent more than 12 years old. The side effect, the common side effect is going with the GI, which is fatty oily stool, the increase or maybe diarrhea, fecal incontinence, and flatus discharge. But to decrease the gastrointestinal side effect, they can use the fiber containing psyllium, so it could decrease the adverse effect. What about the clinical efficacy for the Zenica? It's been in the study is called ZENDOS. ZENDOS, which stands for Zenica and the Prevention of Diabetes in Obese Subject Trial, the largest randomized controlled trial that evaluates the effect of Aristat in around 3,300 patients, was found to cause a total body weight loss around 2.4 after 4 years. And more important, is lower the risk of type 2 diabetes because the weight is being decreased and lower the risk of diabetes. This is making kind of preferable and diabetologists. And the risk of diabetes is kind of significant because reduction is around 9% compared to 6% This is significant over 4 years. And also it is improve blood pressure, insulin sensitivity, lipid profile, whether in direct or indirect use of weight around 2.4% of the initial body weight. The other one, which is kind of, we were hoping would use it for obesity, but kind of been disappointed. And I'm going to talk about it shortly. So lorcaserin, Belvic, has been selective agonist of 5-hydroxytryptamine 2 receptors, approved by the FDA following twice daily 10 milligram dose in 2012. However, in February last year, almost a year ago, the FDA requested withdrawal of lorcaserin from the US market because of potential risk of cancer. It is all the varieties of cancer, pancreatic cancer, colorectal cancer, and lung. And this is making it the way as the risk outweigh the benefits, so it has to be, they recommend to be taken off from the market. On the other hand, is the in European, it's already to start with. They did not approve it from the beginning because of potential risk of the breast cancer. So that was the things is being not used. So lorcaserin now is not anymore in the market. The phentermine topramide. Now we go with the combination. The combo that we're having, phentermine and topramide. Phentermine is the combination. The Kisimia has been approved by FDA in 2012, and this is the first combination agent for long-term management of obesity. While the European, still they have some concern to approve this drug because of potential abuse okay? And the lack of long-term data and cardiovascular effect of phentermine. And the cognitive side effect could happen of topramide, you know, it's the attention, language, and memory impairment. So the European still, they are not approved it yet. What is the mechanism of action? Why this drug, the combo medication, does not have the approval in Europe? So this drug is a combination mainly is to suppress the appetite through the mechanism that remain unclear. And the central sympathetic action of phentermine, a noradrenergic agent agonist, is to enhance the release of norepinephrine, dopamine, and serotonin. Topramide, it's the gamma, the other particle in this combo, is the gamma aminobutyric acid agonist and the carbonic anhydrase inhibitor, and approved for the treatment of epilepsy and the prophylaxis of migraine. So when they observed that significant weight loss will be used by epileptic patients treated with topramide, so this will lead to evaluation, and they make the attention of the scientists to involve it in clinical studies for the treatment of obesity. Although the action of topramide on the central nervous system have not been completely understood, rodent studies have suggested that its act through as neurostabilizer and may boost thrombogenesis. The dose should be escalated gradually. So we used like once a day, and to increase the dose every 3 to 5 days to prevent the complications like insomnia and other side effects. And it's been recommended to be used in the morning to avoid insomnia. The other thing, when we want to stop it, it has to be slow titration down off to avoid or to reduce the risk of seizures. The common side effects of the phentermine topramide include insomnia, paresthesia, dizziness, dry mouth, and the constipation. What about the clinical efficacy? It's in a CUBE study, the mean weight loss after 1 year of participant in this study using phentermine topramide, and the found is the 10.9% reduction of weight compared to 1.6 in the placebo group. And similarly, other study, which is Concur trial, the participants getting the same dose of phentermine topramide, after 1 year, they achieved 9.8. So when we go, it's around 10% reduction over 1 year. It's superior really effect when we compare to the baseline. And the sequel study, which is the extension of the Concur study, and showed that to assess the sustained weight loss, because if you start with the drug and you lose around 10% of your body weight over 1 year, the most important is to sustain this, because the relapse or failure or regain the weight, it's so common with the obese. So the extension of this study, the sequel study, and to assess the sustained weight loss of participants after completion of Concur, and the finding reinforce previous finding that phentermine topramide intake can result in meaningful weight loss and significant improvement in other risk factor metabolic like lipid and the glucose. The other combo, which is the naltrexone bupropion, is Contrave, is the drug combination for the long-term management of weight loss and been approved 2014. And the mechanism of action, it's an antidepressant, and the bupropion is used for smoking cessation. So they make antidepressant with the smoking cessation aid together, and found is to inhibit the dopamine norepinephrine reuptake. And the dose should be escalated to avoid side effects. And it's because of the nausea, it has to be started gradually. And the typical side effect is headache, dizziness, dry mouth, gastrointestinal discomfort, and sometimes vomiting or constipation. then the clinical efficacy weight loss is around 5 to 9%. Now, as the commonest and more famous is liraglutide. You know, as everybody here, you know, the liraglutide has been approved for the treatment of diabetes. And the same as we notice when the diabetic patient, they are using it, they lost weight. So that was the dose is around 1.8 milligram being used for the for diabetes. And then they work it through the particles and they make it like 3 milligram and they call it Saxenda. And you know, it is GLP-1 and they been approved in 2014 for weight management. It is injectable and the escalation of the drug is had to be a gradual. We start with 0.6 and then 1/2 and then to reach 3 to avoid basically the gastric is the GI upset. Like nausea and vomiting. And in the scale, obesity and the pre-diabetes study showed it has the reduction of the weight around 5 to 10%. Now, the combination of the anti-obesity, this is what I mentioned, just we have two combinations. The most being used is the affecting the hunger, appetite, satiety, and inhibition peripheral caloric absorptions. And we have only, as I mentioned early, as phentermine, topramide, and letroxone propropion. Till now, we don't have any more to be approved or any product released in the market recently. So how can we treat? Now we know like we have 5 is initiating and terminating pharmacotherapy for obesity. When do we start? When we terminate? And what are the options that we discuss with the patient? The most important is to risk and benefit. Patient should know what is the mechanism exactly, what expecting from the adverse effect, and what are the goals that should be clear for the patient. It's expecting, I mean, it's not magic that expecting someone is like 140 kilogram and will be like in 2 months, will be like 80 or 70. So the goals, it should be clear with the patient, discuss with the patient. The other thing is patient preference, based on tolerability, adherence, and the cost, because you know, most of the governmental hospital that's not available, and the other thing, most of the insurance that we don't approve, we don't consider obesity as a disease. So it's really difficult is to prescribe one of these medications, and especially if this is being costing more than 1,000 per month. So really, we have to discuss all the options with the patient, and the benefits risk ratio should be clear with the patient's plan. So in conclusion, most current guidelines recommend pharmacotherapy as the second line of treatment for this disorder following lifestyle modifications. And still, even if we use medications, it has to continue with lifestyle modifications. Number 2, pharmacological treatment should be considered as a part of a comprehensive strategy for the treatment of patients with BMI more than 30 or 27 with other risk factors and obesity-related comorbidities. Number 3, the efficacy of medical treatment should be evaluated after the first 3 months of the drug use. And this is important because a patient is coming after 3 months and not getting benefits, why we should continue, especially if it's a narcosis. So I mean, it has to be evaluated after the first and then to see what are the obstacles, what are the things could help to reduce the weight. Number 4, data from most recent meta-analysis showed that the overall placebo subtracted weight reduction with the use of anti-obesity drug for at least 12 months range between 2.9 to 6.8% of the initial body weight. And thank you very much.
السلام عليكم.
Yes. You have to stay or to leave?
No. We cannot leave you.
No, but just we leave the discussion at the end, or we have to be immediate after the.
No. I will tell you the questions. Then we will go with Dr. Badr. Then I will call you on private. Okay.
Okay.
What about Prozac for obesity treatment?
Well, because the Prozac, we cannot say it's antidepressant, we know, but some of the patients, they will get benefit with weight loss and some they will gain weight. So I can't write without having and we can see the antidepressant now we're using with the combination. It's a combo, it's two things. But the Prozac, it's by itself, no, we don't prescribe it. But if it's happened, patients having depression because of the obesity or reason or another, and can get benefits from Prozac, yes, but not every patient can respond to this.
Liraglutide for adolescent can be used after doing hemoglobin A1C. So can you use liraglutide for adolescent?
Yeah, liraglutide is actually for the even for type 1 diabetes if they are obese, not reaching the target, and they are in multiple dosage of insulin. After 10 years, it's been approved since last year. Can be used, which is the liraglutide 1.8 Victoza. So it's the same, but if they are above 12 years old, I think it can be used if this can help.
Okay. Okay, thank you, Dr. Afaf. We'll be back to you. And now, because of shortage of time, we have to go to Dr. Badr. Dr. Badr, are you with us?
Assalamu alaikum.
Walaikum salam, Dr. Badr. Always shining.
Thank you very much.
حضرتك عامل إيه؟
الله يسعدك يا رب.
Wallahi, we are sorry to you, and we apologize also to the attendants because we are a little bit late. But now we are proud to announce for presentation by Dr. Badr al-Mahmadi. Dr. Badr al-Mahmadi is a consultant rheumatologist and associate professor at Al-Majma' University and rheumatology consultant. And today our nice presentation is about crystal-induced arthropathies.
Yes.
Okay, let's share your screen and start.
Okay, Bismillah ar-Rahman ar-Rahim. Is it clear now?
It is clear, sir, yes.
Okay.
And your voice is clear and everything is okay.
Excellent. Assalamu alaikum wa rahmatullahi wa barakatuh. My name is Badr al-Mahmadi. I am a consultant rheumatologist and assistant professor of medicine in Al-Majma' University and in Saudi German Hospital in Riyadh. I'll be happy today to talk to you about the evidence-based guidance for optimizing gout management. Now, I have no disclosures. Today, we'll be talking about the review of the latest American College of Rheumatologists 2020 gout management guidelines, which had been recently published. We will be reviewing some of the supporting evidence behind those recommendations, and we will be reviewing some of the abstracts that have been published in the latest meeting. So before we start with the guidelines, we'll have a quick look about all the previous guidelines that were guiding us into managing patients with gout. We have the ACR, American College of Rheumatologists 2012 guidelines, where they have introduced the concept of target to treat treatment in choosing and titrating the treatment of gout, with a target of about 6 milligrams per deciliter for patients with gout and less than 5 in patients with severe gout. We also have the EULAR 2016 guidelines, where they have included the comorbidities as factors that might play a role in changing and improving the treatment when considering a patient with gout. And then we have the American College of Physicians 2017 guidelines, where it was worked up by primary care physicians. They have basically were aligning their recommendations with the rheumatology recommendations on how to treat gout flares, but they had some controversies in treating to avoid symptoms only and not to avoid other complications from gout that might come later on. I will be discussing a few in a few minutes. And they have also said that the target to treat was inadequately investigated, and therefore should not be considered to be included in the recommendations. Now, our latest guidelines have been based on a lot of new evidence that we will be going through. Now, this is a quick look on the ACR 2012 gout guidelines. Basically, they had about 9 case scenarios, and where they have categorized all patients into those 9 scenarios. And for us physicians, it was our job to try to put our patients into one of those scenarios, and based on that, we can know which would be the best type of treatment for the patient and what should be done next for those patients who have worsening symptoms compared to their previous condition. Now, in the latest guidelines, they have formulated the PICO questions, where they have went into a numerous number of systematic reviews to come up with evidence on each of the outcomes that they have been questioning. A panel of researchers and experts have gathered up to grade also those evidence based on their strength. So a lot of them were graded as strong. Some of them were graded against the treatment, and some of them were controversial in putting it into a strength level. So the questions were broad, and they have included around 30 questions on urate-lowering therapies, 7 questions on lifestyle, 2 questions on alternative medicine, 8 on asymptomatic hyperuricemia, and 10 questions on flares. They have come up with a total of 42 recommendations. 16 of them were strong recommendations based on the new evidence. Now, going through some and highlighting some of the points that have come up in the latest gout guidelines, they have basically said that in order to, as an indication to start a urate-lowering therapy, we have to have at least 1 or more of tophaceous gouts to start the treatment. Otherwise, a patient should have radiographic damage that was attributable to gout, or the patients would have gout flares of 2 or more per year to start the urate-lowering therapy. Now, there was also a conditional recommendation for patients who have 1 gout flare in 2 years, which would not fulfill the previous recommendation. They were also advised to start the urate-lowering therapy if they had chronic kidney disease of stage 3 or more, or they had a uric acid level of 9 milligrams per deciliter or more, or they had some kidney stones. Now, what to start as an initial therapy in those patients? They have recommended strongly the starting of allopurinol over any other urate-lowering medication, even in patients who had a chronic kidney disease of stage 3 or more. And they have also recommended to start it with lower doses and then try to titrate it according to the levels and according to the patient's condition. They have also recommended, and this was a mild change from the previous recommendation, they have recommended continuing the prophylaxis therapy with anti-inflammatory agents such as the non-steroidal anti-inflammatory drugs or colchicine or steroid for a period of 3 to 6 months, where the previous recommendations had it for a period of only less than 3 months. Now, this is an interesting point, which is a conditional recommendation for starting the urate-lowering therapy during a gout flare. Now, as we all know, there were some previous studies that have said that if you start the urate-lowering therapy during a gout flare, that might cause the worsening in the severity and in the duration of that gouty flare. So it was previously advised to wait for at least 2 weeks before starting the urate lowering therapy after the acute attack. But they have based now their conditional recommendation based on the facts that a lot of the patients that they were treating were not keen to come back in a few weeks after the flare subsides to start the urate lowering therapy. And at the same time, starting the urate lowering therapy at the same time of starting the acute gout treatment had the patients motivated to continue the treatment because they have felt the improvement while they were on the treatment. So they wouldn't be favoring stopping the treatment afterwards. So based on those two reasons, they have said that starting the urate lowering therapy was a better choice than waiting for a few weeks. There were also like 2 randomized controlled trials and 1 observational study that has said that starting this treatment during the acute flare did not truly worsen the severity of the acute attack or prolong the duration of it. Now, we also have a strong recommendation against starting pegloticase as a first-line therapy, basically because of the immunogenicity that might come with this treatment. And we'll be talking about some of the literature articles that have talked about this issue and finding solutions for it. Now, in terms of titrating the urate lowering therapy, they have strongly recommended the treat to target strategy, where they had seen an effect on those patients when following up this kind of strategy. Now, in terms of when to switch from one medication to the other, or what were the contraindications to some of those treatments, I can highlight the fact that febuxostat have been talked about over the past few years, that there was a strong link between the use of febuxostat in patients who had cardiovascular disease with new onset of cardiovascular events. So there was a conditional recommendation to start a different urate lowering therapy agent over febuxostat in patients who had a history of cardiovascular disease. And we'll be also talking about some of the new studies that have talked about starting febuxostat and what were the risk in those kind of population. So the bottom line for the these latest guidelines is that it had a meaningful impact on the outcomes in gout. And usually when we talk about the meaningful outcomes in gout, we talk about 3 arms. The first is the uric acid burden in terms of the presence of crystal deposits and tophi in the joints, the joint structural effect and damage such as synovitis and erosions, and then the acute flares in terms of severity and frequency. Now, some of the supporting evidence behind these guidelines is a study that have compared the use of febuxostat over placebo in synovitis scores that were measured by MRI. And we can see that over a period of 2 years, there was a significant and statistically significant difference between the scores of synovitis in patients who had febuxostat compared to patients who had placebo. We can also see that in terms of gout flares, there was also some statistically significant difference between the number of gout flares in patients who received febuxostat compared to the group who received placebo. There was also a study that have looked into the nurse-led protocols where they had been following the treat-to-target strategy in treating and titrating the treatment for patients with gout using allopurinol compared to another group who had been treating the patients in the primary care setting, where they have not considered the treat-to-target strategy, and they were guiding the titration of treatment based on the patient's symptoms. And we can see that in the first group of patients where it was a rheumatology nurse-led treat-to-target strategy protocol was used, we see that the level of urate in the blood had been significantly lowering down with a mean of 250 micromole per liter in the group of patients who received the treat to target strategy, compared to a mean of 450 in the primary care setting group. We can also see that the serum urate concentration had been significantly lowering down over the years. By the end of the second year, we can see that there was a significantly lower number of flares, and there was also a lower number of tophi present in the group that was led by the rheumatology nurse protocol in the treat to target group. Now, there was also another study that had been measuring the amount of crystal deposits in the joints using a dual energy CT. And we can see that in the groups of patients who were using the urate lowering therapy, we can see that there was a significant change and drop in the presence of crystal deposits in the joints over a period of 18 months compared to patients who were not receiving these kinds of treatments. Also, there was also a study that have been measuring the cartilage surface crystal deposits in patients with gout using the urate lowering therapy, and they have noticed that the double contour sign, which is the first of three changes that might resolve in the ultrasound when seeing patients with crystal deposits, was improving in patients who were taking the treatment. And then also there was a significant drop in the number of tophi present and the crystal aggregate deposits in those groups. Now, once they have also tried to compare two groups where one of them had been using allopurinol in steady doses and the second group was using a dose escalation protocol, and they have noticed that there was a significant change in the urate volume using the dual energy CT. And they have also noticed that the erosions were way much less, with a statistically significant difference in the groups with dose escalation compared to the control group. Now, basically in the control group, the level of allopurinol dose was ranging between 300 and 370, where in the dose escalation, it had started with about 265 milligrams, and it was escalated into a mean of 400 milligrams. Now, the question that comes up with every, after the publication of every guidelines is, where would be the gaps that needs improvement in the future for future studies? Now, we can all see that there was a lot of issues that have been, they have been trying to resolve when comparing it to the 2012 guidelines. Basically, the difference between the urate lowering agents and what were their goal in treating those patients. Now they have been stressing more on the treat to target strategy, more than only checking if the patient had any symptoms. But there also were questions about how low should we go with the urate lowering therapy. We all know that going down to very low levels, there was some studies that have been suggesting that there could be some neurodegenerative complications associated with a long-term low uric acid level in the body, and we're talking about lower than 3 milligram per deciliter. Now, the other question is, how quick should we lower down the uric acid level? How long should we continue reusing these kind of treatments? And were we targeting the patient as a whole, or were we only targeting the gout by itself? And when we say the patient as a whole, we talk about all the other complications that are associated with gout, especially the cardiovascular events and the renal events that might be associated with it. Now, the other problem that might come also is how can we treat patients with stage 4 chronic kidney disease who would be always a challenge to treat because of their condition. And they have also not considered the pharmacogenomics of some of the genes that might play a role in the development of gout. And we'll be talking about the ABCG2 gene, where it was recently found that it plays a role in developing gout. And this could be a new pathway for newer treatments. Now, talking about the ABCG2, it plays a major role in the small intestines, kidneys, and liver, and it usually causes and plays a major role in the uric acid excretion and uricorosis in the intestines. But when seeing some mutations in this gene, some of those mutations might cause the development in gout in some of the patients. This was found in 2 genome-wide association studies, where they have found that in a large number of populations, the ABCG2 genome was present. Now, the ABCG2 Q141K variant was found common in a number of groups that were studied, around 10% of whites, 4% of blacks, around 20% of Mexican Americans and Native Americans, up to 30% in East Asian population, and in about 50% in some Chinese and Japanese groups with gout. Now, based on the prevalence of this ABCG2 Q141K variant, should we start screening patients for such a genome as we screen patients for the HLA-B5801 when starting the aripiprazole therapy? Because as we know that mainly East Asians and Africans and African Americans have a higher prevalence of this HLA-B5801, where they might have hypersensitivity to aripiprazole, and that might cause us to avoid using it as a first-line treatment. Now, we have elements of gout that should always be kept in mind when treating the patient. In the recent guidelines, they have considered the comorbidities such as chronic kidney disease and cardiovascular events. Also, we have always been talking about the diet as a major factor that plays a role in treating and managing and sustaining a low uric acid level in patients with gout, as well as using the use of alcohol and some of the medications. But should we also now start considering some of the immunogenicity that might come with some of those medications, and the racial and ethnic backgrounds behind some of those gout patient groups, where they should be considered to be using some medications over the other. Now, mortality is always considered as the ultimate comorbidity, and outcome measures in gout and hyperuricemia. This mortality is always kept in mind. We can see that patients with tophi, gouty patients with tophi, have an increased risk of mortality compared to patients without tophi. One of the trials have explored the effect of colchicine with low doses going down to 0.5 milligram per day as a cardioprotective agent in patients with gout, and there was some statistically significant changes that was seen in those patients compared to patients who were not using colchicine. Now, another question might arise that we also know that colchicine might be cardiotoxic, but this is always considered based on the dose that is used. When we talk about cardioprotection, we talk about doses that are low, as low as 0.5 milligram per day, and higher doses are always the ones that are considered cardiotoxic. Now, in conclusion, for those guidelines, we can see that prescribing the medications should always be in view of the comorbidities and the pharmacogenomics of the patients. Uric acidic and recombinant uricase use should be considered, but allopurinol should always be considered as a first-line agent in most of the patients. We should also consider looking into synovitis, erosions, and other complications associated with gout when treating those patients. Now, when we talk about the cardiovascular safety of febuxostat, which was a large debatable discussion topic in the last few years because of the CARES study that have showed that febuxostat had a higher cardiovascular mortality rate compared to other agents. Now, this study have explored this more, and they have followed up patients with for cardiovascular safety. And basically what they have found was that febuxostat was not inferior to allopurinol for the incidence of cardiovascular events. Basically, they have studied around 6,128 patients where they have divided them into two comparable groups. Well, the first group received febuxostat and the second group received allopurinol for a period of around 4 years. And they have not found any statistical significant difference between the two groups in terms of the cardiovascular safety. In both groups, the death rate was also comparable, where we had about 7.2% of the patients in the febuxostat group and 8.6% in the allopurinol group. So as a conclusion, febuxostat was not inferior to allopurinol in terms of the cardiovascular outcome, and long-term use of febuxostat was also not associated with an increased risk of death compared to allopurinol. Now, a lot of talk have been going on about the use of pegloticase. As you remember, there was a strong recommendation against using pegloticase as a first-line agent in the gout patients, basically because of the immunogenicity. And when we talk about immunogenicity, we talk about drug antibodies, which might make the drug lose its effect, and the patient might start experiencing some side effects because of the medication, as well as some loss of efficacy of the treatment. So as a solution for that, they have been trying to use some medications that might lower down the risk of immunogenicity. So the first medication that they have been looking into was methotrexate. And they were trying to compare the patients who would use methotrexate as co-therapy with pegloticase to a group of patients who were only using pegloticase. Basically, the methotrexate was given at a dose of 50 milligrams per week, and then it was continued with the medication pegloticase, which was given at a dose of 8 milligrams per week. And the patients were studied for a duration of 52 weeks. Now, as a result, they have proven that there was a reduced immunogenicity for pegloticase in the group that had been using the methotrexate. And also the patients who were using the methotrexate were experiencing less side effects because of the medication compared to the group of patients who were only using pegloticase. Now, this is a second study where they have studied around 14 patients who were using methotrexate with pegloticase. There was out of those 14 patients, 11 of them have been responders to pegloticase at the line of 16 months. And when we continued following up those patients for a total of 12 months, it had been shown that only 8 of those patients had remained responders to the treatment. One of them did not extend to the full treatment period, and 2 have discontinued pegloticase as they have met their treatment goals, and then they have continued on allopurinol. So only 3 patients out of the 14 patients were not responders to the pegloticase treatment compared to the rest of the group of patients. In terms of side effects, there was only 1 patient who had developed sepsis, and there was no safety issues observed over the group of patients at that period. Now, when we look into the gout flares during the study period, we can see that about 93% of the patients, which was about 13 patients out of the 14, have experienced gouty flares in the first 12 weeks, and that was comparable to only 25% of patients at the line of 36 to 52 weeks. So as a conclusion, the 6 months response rate for the co-therapy was around 78.6%. Responders at 6 months remained to be responders at the line of 12 months compared to any patients who were not using methotrexate co-therapy with pegloticase. Now, another medication was also tested as a co-therapy with pegloticase to reduce the anti-drug antibodies and the loss of responsiveness to pegloticase, which was azathioprine. The goal of the study was to determine if the presence of azathioprine as a co-therapy would increase the frequency of a chronic refractory gout in patients with gout and lead to persistent urate lowering in patients with pegloticase treatment. So basically, the patients were started on azathioprine at a lower doses, which was then increased to 2.5 per milligram per kg for the remainder of the trial. The primary endpoint was a persistent low serum uric acid level of less than 6 milligrams per deciliter. And patients were also receiving infusion prophylaxis with hydrocortisone in order to prevent any infusion side effects. Now, in this group of patients, there was only 12 patients enrolled. 6 of those patients have completed the full course of the treatment with persistent urate lowering levels. 2 remained on the treatment with persistent urate lowering, but the rest of the group of patients have discontinued the study and were not evaluable for the final endpoints, as some of them had lost the efficacy, some of them had started having infusion reactions, which is an indication of the development of anti-drug antibodies in those patients. There was no adverse events related to azathioprine in the group of patients study, and they have concluded that azathioprine can be used safely in patients with chronic refractory gout using pegloticase. Now, also there was a study that have tested mycophenolate mofetil, which is CellCept, in patients who were using pegloticase as a medication that would lower down the immunogenicity in those patients, compared to another group which was only using placebo for a period of 12 weeks. The endpoints were a primary endpoint was a urate lowering, a urate level of less than 6 milligrams per deciliter at the level of 12 weeks. And they were also assessing the 6 months durability of immune modulation after the discontinuation of mycophenolate mofetil at the level of 12 weeks. And then they were trying to see if there was any immunogenicity that might come after the stoppage of this medication while using pegloticase. And then they were also measuring the adverse events. So 86% of patients in the mycophenolate mofetil arm have reached the outcome at the point of 12 weeks, compared to only 40% of patients who used pegloticase with placebo. and the adverse events per month was similar between the two groups, but there was also a higher incidence of side effects in the azathioprine group compared to the placebo group. There was some musculoskeletal side effects, respiratory side effects, and infections, which were all seen in the mycophenolate, in the azathioprine the mycophenolate group compared to the placebo group. In terms of the infusion reactions, they were seen in the placebo group with an incidence of 30% compared to none in the mycophenolate mofetil group, which is an indication for the development of anti-drug antibodies in the placebo group. So as a conclusion, the short-term concomitant use of mycophenolate mofetil with pegloticase was generally well tolerated in this proof of concept study, and it was associated with statistically significant and clinically meaningful impact on the proportion of subjects achieving and maintaining a uric acid level of 6 milligrams per deciliter at the point of 24 weeks. And we can see that in the graph that the percentage of patients who were maintained on a uric acid level of less than 6 was statistically significant compared to the in the MMF group compared to the placebo group. Now we will conclude with this study, which had the immunomodulation was kept in mind while the treatment of pegloticase was initiated in a group of patients, and they were trying to see how many of the physicians who were treating gout were using the co-therapy strategy when starting pegloticase for their patients to reduce the risk of immunogenicity in those patients. So there was a large group of patients were recruited from the IQVIA database, where it had around 1.3 billion claims from 2014 to 2019, with around 30 million patients diagnosed with gout or a chronic kidney disease using pegloticase as treatment. So any patient who was found to be using a pegloticase and was prescribed one of the two medications as co-therapy by their physicians was included in the study. Methotrexate and azathioprine were the main two medications that were considered for co-administration with pegloticase as immunomodulators in those gouty patients. Now, as a result of this study, the immunomodulation co-therapy rates of those patients was consistently low in the first period of the duration of the study between 2015 and 2018, but there was a marked increase in the usage of immunomodulation and co-therapy in the same group of patients at the level of 2019. The majority of patients who were started on immunomodulation were started within the first 30 days of starting pegloticase infusion. Methotrexate was used way more commonly than azathioprine in the group of patients. Now we can see that there was a dramatic increase in the use of co-therapy in the patients after the period of 2018. So at the level of 2019, the number of the total number of patients have increased by 15% compared to only 1 to 3% in the period between 2015 and 2018, which means that the majority of physicians have been keeping in mind the immunogenicity that is always associated with pegloticase, and they were trying to lower it down by using immunomodulators such as methotrexate and azathioprine. Thank you very much.
Thank you, Dr. Badr.
You're welcome.
It was very nice presentation, Dr. Badr. Thank you. Now for the questions. You hear me?
Yes, I can hear you.
Yeah. First question, sir. What about effect of colchicine on fertility?
Okay, so they have not looked into this. Colchicine was only now we all know that colchicine is used as a prophylactic agent in patients with refractory gout, especially patients who have frequent gouty attacks. And there were some side effects, mainly like GI symptoms that are associated with it. There was some issues with cardiotoxicity compared to colchicine, but it was always advised to start colchicine in those patients. But the infertility was not looked into.
Okay. For the second question, what about management of asymptomatic hyperuricemia?
Okay, so asymptomatic hyperuricemia was not included in the latest guidelines, basically because there was not enough evidence of when to treat and how to deal with patients with asymptomatic hyperuricemia. So that's why it was not included in the latest guidelines. So basically, we'll be following up the same previous recommendations in terms of those patients.
Just to confirm, we are treating, and you revise me if I am wrong, we are treating asymptomatic hyperuricemia if there's family history of stones, or I think urinary uric acid excretion high, or chronic kidney disease, right?
All right. So basically, if there was a hyperuricemia without any evidence of tophi, without any evidence of without having any evidence of tophi or any chronic kidney disease, especially stage 3 or more, or without any acute gouty attacks or complications of erosions that are attributable to the gout. For those patients, it is recommended not to start the urate lowering agents and to start with basically only monitoring the uric acid level and try to make some dietary changes and lifestyle modifications to lower down the uric acid level. It was previously said that any uric acid level of more than 11, or if there was any kidney stones, or if there was any evidence of high uric acid in the urine, more than around 800, or 900, that would be an indication to start not to treat gout, but as a prophylactic measure to prevent the development of kidney stones and the effect that it might come on stones. But for other patients who had a uric acid level of less than 9 without any of those major complications that are usually associated with gout, it was recommended only to observe and monitor and not to start treatment.
Okay, it is clear. Last question, is there any data about monoclonal antibody in management of gout?
Well, there are some recent ongoing studies right now about the monoclonal antibodies, but there are no published research yet about this.
Okay, everything is clear. Thanks, Dr. Badr. We are very happy to have you here. And I still remember last year you gave us a very nice presentation also. I think it was about lupus.
Yes.
Right? There is no other question, and we will end the presentation here. Thanks, Dr. Badr. And now, everybody, I am very happy that everyone is still here till the end of the day. And our symposium finished, our webinar finished. This is the end of the third day. For the missing presentations due to the time factor, I will remind you that we have weekly scientific meeting every Saturday. We will keep posting about it and giving you a hint about all this. And the missing presentation will be back up in the weekly presentations every Saturday around 9 o'clock. And also for the questions raised about the certificates and adding the CMA hours, please check after 1 week. And I would like to remind everyone to fill the online form about assessment of the presentation and the webinar. And I hope everyone is happy right now and willing to hear from you just to improve us and make a better quality webinar next time. Thanks for everyone. Thank you for waiting till now, and goodbye.